Thank you. Good afternoon and welcome to this bill hearing for the House Health Committee. I'm Chair Heather Bagnall. My Madam Vice Chair is presenting our first bill. I ask for your patience if we encounter any technical or streaming issues. This hearing is being streamed on the Maryland General Assembly YouTube channel. We do also have a few virtual speakers today, so again, please give us some grace if we have issues switching back and forth. Please note that food and beverages are not permitted in the gallery. Delegates may have drinks at their desks as these meetings can run long and hydration is essential. Please make sure to turn off your phones or silence them at this time. If a member is not present in the chamber, please understand that they may be attending other official meetings or testifying in other committees on their bills, and they are remaining informed on these proceedings. Please adhere to our usual committee rules of one question and one answer from the panel, not one question and one answer from each panelist, and please keep your questions brief and shorter than the answers. The bills, we're going to be hearing the bills in this order today as of now, subject to people's availability. House Bill 498, followed by 322, 599, 372, 373, 448, 374, and 422. As a reminder, sponsors are not time limited, but please keep your testimony within reason, and all witnesses have 2 minutes. And we're going to start with House Bill 498. This is Certificate of Need Intermediate Healthcare Facilities. Vice Chair Cullison is already at the table, so if you want to get started, and welcome.
Thank you very much, Madam Chair, and thank you for the opportunity to you and the members of the Health Committee. I had to make sure that I said it correctly in my written testimony, for the opportunity to present this bill to you. This legislation designs to give Maryland a balance between the need for oversight and expanded access to care in an area of really critical healthcare need. It's an area that we've heard frequently about, even in the short time we've been here this week. The goal is to protect patients while responsibly expanding access to high acuity substance use disorder treatment. The bill it addresses the needs in the facilities that include ASAM level 3.7, and those are the intermediate healthcare facilities that address it provides 24-hour nursing care and physician-supervised addiction treatment across Maryland. As you know, we've continued to see a high demand for these high acuity treatments. Our capacity is limited, as we've heard in this committee, and the need is persistent and growing in some areas. So it's critically important to help these patients get supportive, specialized, and highly supervised behavioral health and medical attention they need. We need the beds with the right oversight, and HB 498 attempts to make that balance. The patients who need these beds and the kinds of behavioral and medical care that they need are highly medically complex. They're vulnerable individuals. They are facing a moment in their lives when they need the most attentive and clinically responsive care that we can give. We have large and diverse counties in our state, and some of them are seeing a lot of pressure and an increased need for these level 3.7 services for patients who are transitioning from emergency departments, inpatient hospitals, and the justice system. But here's the key. Here's what this bill tries to address. That makes how the capacity expands, the number of beds available expands, just as important as whether it expands, especially for these medically complex patients who require appropriate staffing, space, and clinical oversight. Under the current law, when one of these facilities is being established, a certificate of need process is required, and in order to set up that business. However, no review is required if they decide to expand the number of beds. This gap in oversight has really allowed some of them to triple capacity under their initial approval without any review of staffing, space, or patient safety impacts. In some cases, the facilities have added beds to existing rooms without changing the physical environment, which has led to multiple beds in a single room. Unregulated capacity expansion can undermine clinical effectiveness and strain our staffing ratios. It can compromise patient safety. It can put as well as put our healthcare workforce in danger, our patients in danger, and ultimately risk the treatment outcomes. We've heard about investigative reporting that has highlighted the need for these treatment, for more treatment capacity and oversight. I think we had a hearing about this just a couple of days ago, but who knows, because I can't keep the days straight anymore. Simply stated, this bill establishes, with the Maryland Healthcare Commission approval, this bill establishes the need for MHCC approval before a level 3.7 facility can add beds. And this is critical, I need everyone to understand. It creates a streamlined, expedited public interest review, not a full certificate of need process. Under this review, this is what MHCC would be looking at, and that we definitely want to make sure that the facility is complying with our state health plan standards, that they have appropriate staffing for the beds that they're adding, that they have accredited staff, that they have appropriate admission and treatment protocols, and that their physical space is configured correctly so that they are serving medically underserved patients who have no other place to seek care. So there's some protections put in place for both the facility and for the patient access. The MHCC has 45 days to complete this review when the request is made, and competitors cannot intervene in that 45 days. It fundamentally closes a loophole in our current regulatory oversight process while providing a faster, clearer pathway for both facilities and responsible expansion. As you just heard our governor say, Maryland families deserve safe, high-quality, and accountable health care, including substance use disorder treatment options. And that's what HB 498 does. It strikes the right balance, more access, better oversight, stronger protection for patients. For these reasons, I strongly support HB 498 and ask you for your favorable consideration of the bill. Thank you. And I'll turn it over to Mr. Jacobs, Dr. Jacobs.
Chair, Vice Chair, thank you. Members of the committee, thank you for the opportunity to testify. My name is Doug Jacobs, and I'm the Executive Director of the Maryland Healthcare Commission. MHCC strongly supports House Bill 498. House Bill 498 addresses a clear regulatory gap in how Maryland oversees high acuity substance use disorder treatment. Under current law, MHCC reviews the establishment of intermediate healthcare facilities, those level 3.7 facilities that you just heard about, that provide medical detox for persons with substance use disorder. But once approved, there's no oversight when those facilities dramatically expand bed capacity. This bill restores consistency, accountability, and transparency. And we've seen the real-world consequences of this loophole. In one case we saw just a few years ago, a facility went from 21 beds, expanded to more than 120 beds without any review. This led to, in some cases, to having 6 patients per room undergoing medical detoxification, an extreme level of overcrowding. This is a health and safety problem because overcrowding in behavioral health settings has been shown to lead to increased violence, suicide, and injury. House Bill 498 strikes the right balance between access and oversight. It creates an expedited public interest review process requiring a decision within 45 days. And at the same time, patient protections remain front and center. Facilities must demonstrate compliance with state health plan standards, including accreditation, staffing, admissions criteria, treatment protocols, physical configuration, and serving the underserved patients. and must also demonstrate that the project serves the public interest. So this legislation creates a single consistent framework for all intermediate healthcare facilities, new or expanding. And it increases oversight where it's clearly needed. It accelerates approvals where access is critical and closes a loophole that undermines confidence in the system. In short, HB 498 benefits patients, families, and providers alike. For these reasons, MHCC respectfully requests a favorable report on House Bill 498. Thank you.
Good afternoon, Madam Chair and members of the committee. I'm Winnie Hawk. I'm with the Maryland Healthcare Commission. I'm the center director that oversees this review process, and I'm just simply here to answer questions. So thank you very much. I'm happy to be here today.
Thank you for your testimony. I'm going to go ahead and open it up to our members. Are there any questions for this panel? Seeing none, thank you very much for your testimony.
Thank you, Madam Chair.
We do have another favorable panel. So if I can get Sarah Haregrove, Ryan Chamberlain, and Lauren Graziano. And you can begin as soon as you're ready.
Madam Chair, do you care what order we go?
That is at your discretion.
Okay. Good afternoon, Madam Chair and members of the committee. Lauren Graziano here representing Gadenzia. We are a substance use disorder treatment provider here in Maryland, and we have programming all in the Mid-Atlantic region and our neighboring states of Pennsylvania, Delaware, as well as programs in DC. We are here today in strong support of HB 498. The sponsor panel did an excellent job of summarizing the bill and telling you what it's about, and so I will simply say us too, and we ask for the committee for a favorable report. Thank you so much.
Good afternoon, Chair Bagnall, Vice Chair Cullison, and members of the committee. My name is Sarah Haregrove, and I'm the Assistant Director of Policy at the Community Behavioral Health Association of Maryland, or CBH. CBH is a leading voice for community-based behavioral health providers serving vulnerable Marylanders. Our 95 members provide outpatient and residential treatment for mental health and addiction-related disorders, serving the majority of those in the state's public behavioral health system. Notably, CBH represents about 20% of providers that this bill would impact, licensed residential substance use disorder treatment programs that are subject to Certificate of Need regulation by the Maryland Healthcare Commission. On behalf of our members, we're pleased to support House Bill 498. We believe that this bill establishes a streamlined, consistent review process for the expansion of existing treatment programs and the development of new programs. Throughout, MHCC maintains substantial oversight, holding existing and new providers to the high-quality standards laid out in our state health plan. This revised oversight model will result in a more comprehensive and efficient licensure process with a lower administrative burden than the traditional Certificate of Need process would require, allowing this level of care to reach the communities who need it more efficiently and effectively. We appreciate this proactive approach to regulation by the MHCC and recognize MHCC's positive history of engaging with providers it regulates and addressing their concerns. We feel that this bill seeks a balanced approach, reducing burden across the board without sacrificing quality of care. We respectfully request a favorable report on House Bill 498. Thank you.
Thank you very much for your testimony today. I really appreciate you coming. Are there questions of this panel? Seeing none, thank you all. And that concludes the hearing on House Bill 498. And we will move to House Bill 0322, Maryland Health Care Commission. I'm looking, yes, he's here. Okay. Membership, and this is Delegate Kerr. And Delegate, I'm not used to seeing you there and not there. So
I'm not used to being there. I was tempted to walk in the door and take my seat, but I see that Delegate Martinez is already occupying it.
You are always welcome, Delegate Kerr.
Well, thank you. And let me just say how much I miss all of you, and especially Lindsay. But it's good to be here again. So I'm Delegate Ken Kerr. I'm here today to present House Bill 322, Maryland Healthcare Commission membership. So the Maryland Healthcare Commission is responsible for studying, planning, and regulating major parts of Maryland's healthcare system. Despite this broad oversight, hospitals remain one of the few major healthcare stakeholders without a designated seat on the commission. HB 322 addresses this issue by adding a hospital representative to the Maryland Healthcare Commission, ensuring that hospitals have a formal voice in decisions that directly affect them and the communities they serve. For example, the Maryland Healthcare Commission oversees the Certificate of Need program, which reviews and approves new hospital bed capacity and whether to build or develop new or future health facilities. Additionally, other key stakeholders, including nursing homes, physicians, other health insurers, have a designated representative on the Maryland Healthcare Commission. So adding a hospital only makes sense. At Maryland Healthcare Commission's request, we're offering a technical amendment that would change hospital representative to hospital administrator. This wording more accurately matches the commission's existing membership structure and terminology. We reviewed the bill with the Maryland Healthcare Commission, and they've approved the bill. And we would like to thank the MHCC leadership and staff for their valuable input on this legislation. So HB 322 ensures that hospitals, as a vital part of Maryland's healthcare system, finally have a seat at the table for these critical healthcare issues. So I would ask for your favorable report.
Thank you. Mr. Whitaker?
Great. Thank you, Madam Vice Chair and members of the committee. I'm Jake Whitaker on behalf of Maryland's Hospitals and Health Systems, here to testify in support of House Bill 322 as amended. As Delegate Kerr laid out, this bill is very straightforward. Right now, insurers have 2 seats on the Maryland Healthcare Commission. Nursing homes have a seat. Physicians have 2 seats. But hospitals, one of the most heavily regulated parts of the system, don't have representation at all. The Maryland Healthcare Commission, as Delegate Kerr mentioned, plays a huge role in how healthcare works in our state. It oversees cost, quality, access, major regulatory decisions, and statewide health system planning. The commission also looks at things like healthcare utilization, cost trends, as well as payer transparency and accountability rules. Additionally, as Delegate Kerr mentioned, a really important function of what the MHCC does is the Certificate of Need process. So that really means that hospitals can't expand, relocate, or build major services without the commission's approval. And what's really important is that that CON process plays a very important role in determining the number of beds within a hospital, as well as what services that hospital provides. So given all that authority, especially over the healthcare system and the hospital system as a whole, it doesn't make sense that hospitals don't have a seat at the table. So House Bill 322, as amended, addresses that issue by placing a seat at the table, hospitals on the commission. So for the reasons that Delegate Kerr laid out in his leadership in addressing this bill, we respectfully ask for support as amended on this legislation. Thank you.
The committee. Okay. Delegate Hill.
Thank you. Thank you, Delegate. So good to see you, Mr. Vice Chair. I don't know whether, I guess, Jake, you can answer the question.
Sure.
This was formed, the MHCC was formed in 1999, and it was deliberately designed without a hospital representative on it. And I understand hospital representation is on some of its subcommittees, right?
There have been members that represent hospitals that have served in the non-designated seats for hospitals, but we think it makes sense to have a designated seat for hospitals given the role that the commission plays over the hospital system.
So the question I have is, can you help us understand why that deliberate decision not to have hospitals was made and what has changed about the charge? Because I don't think from what you described, it's the same charge. Why, in other words, it was deliberately done, and hospitals have representation on a lot of other commissions and boards. So.
Sure, I can't speak to the process in 1999. I can say that we've worked very closely with the Maryland Healthcare Commission on this legislation. We've consulted with them down to kind of the language that we've used to kind of represent the commission. So we feel comfortable, especially kind of their regulatory role in overseeing the CON process, things like prior authorization, that we think it's important that hospitals have a seat at the table.
I want to, before I move on to Delegate Ross, Jake, I'm not sure the role MHCC plays in a prior authorization?
Yeah, so the MHCC issued regulations in the fall that related to the prior authorization legislation that was passed a couple of years ago. So I was just referencing that.
So they developed the regulations in response to the bill that was passed?
For part of the legislation.
Part of it.
Yep. The MIA also plays a role in that legislation as well.
Okay, all right, thank you. Delegate Ross.
Thank you, Madam Chair. I really had the very same question as Delegate Hill, and just trying to figure out, because it seems like it's so obvious that there should be hospital representation. There seems like there would be a reason. So, and I know you can't know, like, what the decision-making was around that at the time, but just wondering, and I'm going to unfairly probably ask you to be your own opposition here, but for what reasons might there be to not have hospital representation? Like, is it some sort of, over influence that they might have? And maybe the way to balance that or to temper that down was to have the subcommittee representation instead?
So I appreciate the question. I don't want to speak out of turn or just speculate on why they left us off the table. But I will say and just reiterate that we've worked very closely with MHCC. They've been aware of this legislation and they don't have any opposition. So we feel whatever those concerns may have been in the past, they don't apply here because we've consulted the appropriate stakeholders.
You definitely have, yeah.
Great.
Thank you.
Thank you.
Delegate Hill, a quick follow-up?
You were saying that, you said the certificate of need was one example. Wasn't that done through a work group, and that work group did include hospital representation?
Which work group are you referring to, Delegate?
So you said that, our pre-authorization, I think the vice chair asked about, you said they have authority over certain things.
Yes.
And I guess my question is, when they exerted the authority over that, did they not include hospitals in the work group that was making those decisions?
Yes, so I will credit the MHCC. They circulated for public comment and for preliminary public comment for those regulations that dealt with the prior authorization legislation. But I think to your point, the insurers also played a role in that, but they also have a seat at the table on the Healthcare Commission. So I think if they have a seat at the table overseeing things like the prior authorization process, it only makes sense that hospitals do as well.
All right, thank you.
Seeing no other questions, that completes the testimony for House Bill 322 and the hearing on this bill. Thank you very much, Delegate Kerr. We look forward to seeing you again soon, I think.
Right, do I have to leave?
I suspect that your chair and vice chair are waiting for you to return. And you are the vice chair. I suspect your chair is waiting for you to come, Mr. Vice Chair.
I reluctantly take my leave.
Thank you. We are going now to House Bill 599. This is Delegates Hill and Smith. Delegate Hill is here. This is health, licensure of hospitals, ownership requirements.
Good afternoon. Madam Chair, members of the Health Committee, my name is Terry Hill, and another simple bill that does a simple little thing. I just want to start off by reading a little bit from a December 16th, 2024 article, just to kind of set the things here. This is Media Manager, Office Committee of Health Equity, Health Policy article. Throughout 2024, eye-opening news headlines from around the country trained a spotlight on the collapse of Steward Healthcare. Steward Hospital's CEO's $40 million yacht was docked in the Galapagos Islands while 6 patients collapsed waiting for care in an overwhelmed Steward Hospital emergency department. Steward Healthcare filed Chapter 11. Steward owned more than 30 hospitals across Arizona, Arkansas, Florida, Louisiana, Massachusetts, Ohio, Pennsylvania, and Texas. And they had started in 2010 as a private equity firm. They purchased Caritas Christi Healthcare, a struggling Eastern Massachusetts hospital. And then in 2016, 6 years later, they signed a sale leaseback where they sold the property and then began to lease it back. In that deal, they made $125 billion. And then they began to expand and purchase 26 more hospitals across the country. By 2020, 4 years later, they've made $800 million in profits, decided to sell the hospitals, and over the next several years, Stewart Hospitals mounted as the company opted to cut costs and neglect bills in order to keep up with the rent payments. Then they fell about $50 million behind in their payments. They continued to pay their leadership and their stockholders, and then eventually they closed down, selling all their hospitals, both to mixed non- and non-for-profit hospital systems, but 2 hospitals didn't survive. One was Kearney Hospital, which served Boston's low-income, majority Black and Hispanic southern neighborhoods. The other was Neshoba Valley Medical Center, which served 17 suburban and rural communities across Massachusetts. So I'm bringing that up not because Massachusetts and all these other states have necessarily a nexus with Maryland, but because this same pattern we have been seeing with regularity across the country. And while our total cost of care model protects us, we don't have any for-profit hospitals in the state. We know with the HED and all the other changes that our system is changing. And this bill simply says that a hospital here in Maryland can only be sold to a not-for-profit entity. It is an effort to try and protect our hospitals. We've not protected our practices, but to protect our hospitals from falling under the for-profit model that's cannibalizing much of our healthcare system and causing many communities around the country to go without basic hospital care. Most recently, Chester, Pennsylvania, which is 90 minutes up and is an important, it's a base home for me and my family. Chester Crozier, their huge medical system, was sold a few years ago, and last year they closed. And those folks have to travel for simply emergency room care, 30, 45 minutes to be taken care of. So that's what this bill does. It doesn't really impact our current stakeholders in Maryland hospitals, but it is a small guardrail that we can put up in a very volatile healthcare landscape to try and make sure that we don't have to face these problems in the near or far future.
Questions? Delegate Hutchinson.
Thank you, Delegate. I have a 7-point question to ask you.
Please, let me take some notes.
To do. No, just to simplify, because I think you said it, we don't have non-for-profits here in the state. The regulatory environment doesn't really encourage for-profits to come here. You're just trying to be protective to say?
Yeah, I'm trying to be protective, and I will say that we do have private equity in our practices, and we have had problems with our hospital closures in the state that have happened without much notice and much ability for us to do anything about it. We just like to make sure that, again, as our healthcare landscape continues to shift in an unpredictable way, that we're covering our tails.
Okay, and then my second note.
Yeah.
I'm good.
Delegate Saliga.
Thank you, Madam Vice Chair. I have an 8-point question
Yes,
that I'd
please.
like to follow up with. So if I'm understanding your bill, it seems quite simple. You just want to forbid for-profit hospitals from operating in Maryland.
Correct.
So ChatGPT had a great, I guess, if the governor, wrote a speech using ChatGPT, I'm gonna, our for-profit hospitals, good actors. And it said, yes, it listed a bunch of for-profit hospitals. So I'm not sure, why would you put a blanket on that model of care?
So let's sort of right set what the differences are. So generally, for-profit hospitals prioritize investor returns. And we have seen, as private equity has moved into the healthcare arena with greater and greater penetration, that patient care often falls behind. There's a lack of transparency, and there's no charity care, or little charity care. Not-for-profit hospitals, even if their CEOs are making a pretty good amount of money, they have obligations to the community and to the state. They are required to have benefits for the community. They're required to do charity care. They're required to do Medigap filings, which allows for us to see what their financials are and to get some understanding of what's going on. So they can be good actors, but what we're seeing at an increasing rate, and I can get you those numbers, is the for-profits essentially acting like the bad actors in other industries did as we saw in the 1980s and then the 90s and so on, just come in, rape the profits out, take the value out, and then leave them limping along.
I would counter that this is a very regulated market. So, I'm not sure those assertions would always hold true. This community health systems, ChatGPT, so I'm just telling you, they focus on community hospitals in smaller cities. They have 75 hospitals in mostly mid-sized rural markets. There's quite a few of them, and I don't have enough information on those to opine with you on that. But, for-profit things can be efficient, disciplined operators that will offer competition. Just because something is nonprofit doesn't mean they're controlling the pay of their CEOs and other people that work in the hospital. They're advertising. I see quite a bit of advertising for hospitals, and I've asked the Hospital Association before, why are we spending millions and millions of dollars advertising on TV for hospital care, where if it was for-profit, that would clearly be one of the first things they would probably cut, because, they're looking at how to at least break even. So, I would just say I'm not sure your blanket assertion on for-profit, not for-profit, would deliver the best outcome for patients, because we all agree on that. We want the best outcome for the best price with all the patient safety and everything, that we can.
Yeah, and I don't disagree. I would say that it was not meant to be a blanket assertion, but there's no question that, we say, for instance, 2023 study found that Medicare patients at private equity-owned hospitals suffered a 25% increase in hospital-acquired complications compared to Medicare patients at hospitals not owned by private equity. This included 38% increase in bloodstream infections from central lines, longer-term surgically inserted ports, despite 16% fewer central lines placed. So yes, everybody can be a good actor, and everybody can be a bad actor, right? But what we're seeing is a pattern, and the pattern has become really clear over the past 10 to 15 years, and I don't think that we should leave ourselves exposed. When we see something, we do something. And so, yeah, we could have great actors. We could.
And that might help curb cost and
well,
create
except it
competition.
doesn't tend to. I mean, so the arguments that if we get, private equity to run, telecommunications or grocery stores or whatever else, whatever they run, they're going to run with greater efficiency, just hasn't been borne out. It just hasn't.
Thank you.
It sounds good, but it doesn't prove to be the case.
Well, we have the highest ER waiting times in the country, and
Absolutely.
we're all not-for-profit.
And it would be horrible if that got, it would be horrible if it got even worse.
I don't think we could, but,
we could. I promise you we could.
Continue that discussion for now. I'm going to go to Delegate Morgan.
Thank you, Madam Chair. I was just going to give the scenario. If a private equity or a private hospital came in, what happens if their care was just outstanding and people wanted to utilize it? Shouldn't they have that option?
Not here in Maryland is what I'm saying. Yeah, no.
Fair.
Okay.
Okay, any other questions? I did have a question, Delegate Hill. So speaking of emergency rooms, I believe that a lot of the staff in emergency rooms now are private equity firms, and the hospitals are actually bringing them in. Am I correct is that a
I
correct?
think that is true.
Okay,
Right.
so,
And a lot of our care, so a lot of our services, so radiology, oncology, urology, a lot of our medical care is being provided through equity-owned, large corporate healthcare entities. Yeah.
and would you say that that has significantly increased over the last decade?
Oh, it certainly has.
Okay. Thank you. Thank you very much. Any other questions for Delegate Hill? Seeing none, that completes the hearing on House Bill 599. And we will bring up Delegate Lopez for House Bill 372, Hospitals, Emergency Pregnancy-Related Medical Conditions Procedures. And Delegate Lopez, I have Catherine O'Malley, Virginia Vasquez-Rios in person, and Jan Creeves. Just starting this. Excuse me.
Thank you. Good afternoon, everyone. Chair Bagnell, Vice Chair Cullison, fellow members of the Health Committee, thank you for the opportunity to testify today. For the record, I'm Delegate Leslie Lopez of District 39, and I'm proud to sponsor HB 372. At its core, this bill is about something very simple. What happens when someone is having the worst day of their life and shows up at an emergency room needing help right now? For decades, federal law under the Emergency Medical Treatment and Active Labor Act, EMTALA, has made a clear promise. If you arrive at an emergency department in a medical crisis, you will be evaluated and treated. That promise has saved countless lives. But in the wake of the Dobbs decision, the Biden administration issued guidance affirming that EMTALA applied to emergency abortion care. However, because the Trump administration withdrew this guidance, that promise of EMTALA is no longer as secure for patients experiencing pregnancy-related emergencies. If the federal government won't enforce EMTALA for emergency abortion care, Marylanders are left vulnerable. There is no state law or state mechanism that mirrors the requirements in EMTALA. House Bill 372 will provide the tools that Maryland's Department of Health and the Office of the Attorney General need if there is an unfortunate accident where emergency abortion care is denied. Physicians have warned us about the dangers of waiting until a patient is sick enough before intervening. That is not medicine, and that is not acceptable. And this is not just happening elsewhere. News reports have described a case at a Baltimore hospital involving a patient with a preterm premature rupture of membranes, a serious, potentially life-threatening complication, and they were denied timely reproductive care. You will also hear testimony from Maryland's practitioners who will explain how delaying emergency care in these situations can have devastating consequences, not only for a patient's immediate health, but for their ability to have children in the future. This bill creates a clear, consistent standard of facility care or facility standards across all Maryland's hospitals. A patient's access to life-saving treatment should not depend on which hospital an ambulance takes them to, how that hospital is affiliated, or how close they are to crossing state lines. In an emergency, the facility standards should be the same everywhere in Maryland: prompt, evidence-based, and centered on the patient's survival. HB 372 is narrowly tailored. It applies only to emergencies, and after amendments to last year's bill, coordinated by my Senate co-sponsor, Crossfile, Maryland's hospitals are neutral on this bill. Finally, let me be clear. Nothing in this legislation
forces an individual provider to act against their conscience. Existing protections remain fully intact. What this bill does is ensure that when life-saving care is denied in an emergency, the Maryland Department of Health has the tools it needs to act and protect patients. In an emergency, no one chooses where the ambulance takes them, but everyone deserves to know that wherever they land, their life will come first. I respectfully urge a favorable report on HB 372. Thank you.
All right, hi, thank you so much for the opportunity. I'm Dr. Vasquez-Rios, one of the OBGYNs here actually in Annapolis with Luminous Health, and I wanted to bring up that complications associated with pregnancy or arising during pregnancy can be something that is new or can actually be an adjunct to pre-existing conditions that worsen during pregnancy. They can be sudden, they can also progress quickly, and a single complication can be life-threatening to these patients and can even cause death. Because of this, EMTALA must cover abortion care so access to life-saving care is protected. Practitioners face uncertainty and fear since Dobbs and all the legal ambiguity that it has created. And this has resulted in some delays, ethics committee consultations, and so on that have become dangerous for emergency care and pregnancy patients. Writing these standards in Maryland law would remove ambiguity and ensure practitioners are fully protected to care for their patients. This would also protect hospitals and healthcare staff from retaliation for doing what medicine requires for pregnant patients in these emergency situations. So in conclusion, this legislation ensures that federal emergency care obligations function in practice. It aligns state law with longstanding medical ethics and guidelines and reduces delays that protect providers and keeps patients safe and alive.
Thank you. Good afternoon, Chair Bagnell, Vice Chair Cullison, and esteemed members of this committee. My name is Katie O'Malley, and I'm the Executive Director of the Women's Law Center of Maryland. We're a nonprofit legal organization dedicated to protecting physical safety, economic security, and civil rights of women and their families across Maryland. And we strongly urge a favorable report on this bill. The future of federal enforcement of EMTALA is uncertain. Any shift in federal interpretation or enforcement would have devastating consequences for women's health across our country. Because most states, including Maryland, have not codified EMTALA protections into state law, Maryland residents right now remain vulnerable to changes at the federal level. Senate Bill 372 provides a critical legal safety net, ensuring that patients continue to have access to emergency medical care regardless of the evolving national landscape. Thank you so much for hearing from me, and look forward to any questions afterwards.
Good afternoon, Robin Elliott. I'm here today on behalf of the Women's Law Center of Maryland, as well as the American College of Nurse Midwives, in full support of this bill. At the core, what this bill is a facility regulation. And this committee looks at and enacts many facility requirements, whether it's hospitals, nursing homes, or other types of facilities. So just wanted to sort of spell out like what kind of bill this is, and happy to take any questions and ask for a favorable report.
And you have a virtual witness on this panel, correct? Jen Krebs, if you want to go ahead and start your testimony.
Thank you. Chair Bagnell, committee members, thank you for this opportunity to speak in support of this bill. You know, when EMTALA was passed in 1986, it was because any factor could be used as a reason to dump. Race, lack of insurance, anything. Dumping means refusing treatment or improperly transferring people with an urgent health concern. The law specifically acknowledged pregnancy by including labor as a covered condition. Abortion care is health care, and pregnancy care, pregnancy health care, includes abortion. I also want to mention that there are many other similar conditions, such as an incomplete miscarriage, pregnancy bleeding that will lead to an inevitable pregnancy loss, that might be confused with the aftermath of an abortion. people don't listen to women in pregnancy sometimes, and that increases risk. We don't need to be debating why someone should or should not receive care. Additionally, as midwives, we believe that both professional and biomedical ethics requires care, EMTALA care, that would resolve an emergent issue and stabilize the woman to permit safe transfer. And it's every facility's responsible to ensure that that care is provided. An individual can have a conscience objection. A hospital must not. Thank you.
Thank you. Are there any questions for this panel? Delegate Rosenberg.
Thank you, Madam Chair. Delegate Lopez, you mentioned the existing protections in Maryland law. Could you, or one of the other panelists, whoever's best positioned to do it, describe for the committee what are the protections in Maryland law, the conscience protections for an institution or for a care provider that would not be disturbed by this bill?
Whichever we do.
So Delegate Rosenberg, just lifting up that there are provisions in law which permit an individual healthcare practitioner from essentially not participating in abortion care. Delegate Lopez's bill does not change that provision of law at all.
In the institution?
The institutions in this case, because of the way that the law is structured, they could refuse care under existing law. What this does is provide that in an emergency, that the hospital does need to provide care. And this is something I know that Delegate Lopez and the sponsor of the cross-file worked fairly closely with the Hospital Association to make sure that what is in this particular bill mirrors what is already required in EMTALA. So nothing additional is required of hospitals. What this does is just give Maryland a clear enforcement mechanism should the federal government choose not to enforce EMTALA around abortion care.
Thank you.
Delegate Morgan.
Thank you, Madam Chair. I was just reading legislation. In the term certain circumstances for allowing for pregnancy termination, that's a vague clause in there. Can you give me some examples of certain circumstances where this would be utilized? Whoever.
So I will say that on behalf of the American College of Obstetrics and Gynecology, they purposely choose to not list any specific conditions because the pregnancy conditions, the risk, the health status of the patient is very tailored to that individual. And so what might be a big issue for someone might not be a big issue for another person, depending on all of the healthcare conditions that they have. I will say, apart from that, that some examples can be for people that have heart conditions, so something that might have been genetic from birth. I will say that for people with heart conditions, pregnancy can sometimes end in up to 25% of morbidity or mortality for those people, as well as infection, bleeding to the point of hemorrhage, and other malformations and genetic conditions that are unrelated to something like a miscarriage. All of those can be life-threatening, all of them can be severe, but the decision-making is made with the patient and with the practitioner. We cannot provide a list specifically.
So, brief follow-up. So would certain circumstances also include a mental state of mind, such as depression?
It would have to depend on the patient's clinical status to know if it is that severe, requiring emergency care, but there has been a couple of instances where I have seen it be that severe, where the patient is threatening suicide and is in need of that kind of care.
Okay. Thank you. Thank you, Madam Chair.
Delegate Kipke.
Thank you, Madam Chair. Federal Title VII of the Civil Rights Act requires employers such as hospitals to make every effort to accommodate their employees' religious exemptions, rights of conscience, unless doing so would create a hardship for the employer. Do you see, whoever's best to answer the question, do you see this new requirement on the hospital, would this create a hardship that could create a conflict between the hospital and the sincerely held religious convictions of their employees?
Sure. So thank you for your question, Delegate. I'm thankful for this question because it serves as a reminder that EMTALA has been federal law since 1986. So we're not adding any new requirements for hospitals. It's the same conditions they've been operating under since 1986.
Can I ask a follow-up? Thank you. So I'm just quickly learning about this. So EMTALA, the statute, speaks to childbirth and delivery. It does not speak to abortion. The quick research I'm doing here tells me that abortion was added by the Biden administration. This is a newer subject for me, so I don't have a lot of...
Sure. So I would answer it with a slight variance. This has been federal law since 2022, I guess, or 2020. So, I mean, again, there's no new regulations added for what hospitals' facility requirements are.
Thank you.
Delegate Hutchinson.
Thank you, Madam Chair. So Delegate, how does this affect like our faith-based hospitals, St. Joe's, Mercy, Holy Cross? What happens in facilities like that?
This standard is applied across the board.
That in those facilities, they would be able to take this level of care if necessary with the hospital would not, would the hospital have any say on whether that can occur or not?
If there's an individual at the hospital who is uncomfortable performing these life-saving procedures, then there's accommodations that are made for, conscientious objectors. But again, there's no new standards that are being applied to hospitals religiously affiliated or otherwise.
Okay, thank you.
Seeing no further questions. Delegate Rosenberg wants a second bite at the apple.
Thank you. Do hospitals currently have procedures to deal with this situation? You're nodding yes.
Yes.
Thank you.
Thank you. Seeing no further questions, that completes the testimony of this panel. And we have, I believe, another, I've lost my notes. Oh, there we go. Sorry. We have another favorable panel. So if I can bring Daniel Vasquez and Robin Elliott was on there, and Christine Crone. And you can get started when you're ready.
Thank you. Good afternoon, Madam Chair, members of the committee. My name is Danielle Bastekis, and I am a student attorney with the University of Maryland Public Health Law Clinic. I'm here today to testify in support of House Bill 372. And I hope this clears a few things up. This bill simply embeds existing federal law into Maryland state law. I'm favorable for two main reasons. First, the Emergency Medical Treatment and Labor Act, or EMTALA, includes protections for pregnant people, including abortion care when a physician determines that it is necessary and has since 1986. And two, EMTALA is on stable grounds given the state of the current federal administration, and to remove these protections would be inconsistent with Maryland state law. First, EMTALA includes various medical procedures when a patient presents in an emergency situation, and does so regardless of insurance status. This bill does not change the law. And in fact, no one's opinion here today about abortion is relevant for what's at stake, given the fact that Maryland has already guaranteed the right to abortion in their Constitution. What matters is a physician needs to have the ability to perform what they determine is necessary care in consultation with their patient. Second, the United States Department of Health and Human Services removed guidance recently affirming EMTALA's protection of abortion care in June of 2025. This has caused concern for many providers and scholars that this administration may restrict abortion care under EMTALA. To restrict this care would be inconsistent with Maryland law. These protections are necessary in the wake of such uncertainty, and for these reasons, I urge a favorable report of House Bill 372. Thank you.
Good afternoon, Chair Bagnell, Vice Chair Cullison, and members of the Health Committee. My name is Christine Crone, here on behalf of the Maryland section of the American College of Obstetricians and Gynecologists. I won't repeat the previous panelists' comments. I would just like to add that Maryland section of ACOG feels so strongly about this piece of legislation that they included it as part of their Advocacy Day asks. We urge the committee to vote favorably. Thank you.
Are there any questions from the members for this panel? Delegate Kitke.
Thank you. Christine, is my understanding accurate? Without this bill, Maryland hospitals through the ED are all required to stabilize someone. They can't just send them away. What this bill does is it creates the requirement that St. Agnes participate in carrying out an abortion. Is that accurate?
If it's to stabilize the patient, then yes, I believe that's accurate.
But aren't all of Maryland's hospitals, without this bill, required by law to stabilize that person, that woman, without this bill?
They are, but I think the confusion coming from federal guidance is making physicians second guess whether they should be providing the care, and this Maryland bill will clarify that.
But it also adds a new requirement that they participate in the abortion.
It actually doesn't add any new requirement. This is embedding federal law into Maryland state law. And once the patient is stabilized, there's an option to transfer the patient. And that's consistent with EMTALA.
Can I ask a clarifying question?
Sure.
I think I understand what you're trying to clarify, and I also want to make sure that we are all clear. This is not changing existing law or existing practice, as I understand it. This is simply taking that federal law and codifying it in state law so that there is clarity across our entire hospital system should the feds alter the existing federal protections. Is that accurate?
Correct.
So it does not change best practice, it doesn't change standard of care, it doesn't change the current practices at our state hospitals. It just, or I should say, our state system, because we don't have state hospitals, they're nonprofits, but it doesn't change any of our current practice. It simply codifies and clarifies that going forward, regardless of what happens at the federal level, Maryland will continue to adhere to our current practices. Is that accurate?
Yes.
Okay, thank you very much. Are there any other questions from our members? Thank you very much. That concludes this panel. We do have an unfavorable panel. I have Dr. James Kelly and Laura Bogley. Wait. And then we'll go to the unfavorables, and then we'll go to a virtual favorable and virtual unfavorable to be fair and balanced, and because I read my notes wrong.
Thank you, Madam Chair, Vice Chair, members of the committee. I'm Laura Bogley, Executive Director of Maryland Right to Life. We urge your unfavorable report on this bill that is not about emergency pregnancy-related medical conditions, but about emergency abortion-related medical conditions. Maryland law needs to clarify these definitions to create the medical certainty to resolve this problem. It's that simple. We need to clarify our terms in the code. But this bill, though, is an attack on religious freedoms of medical providers guaranteed by the First Amendment and protected under Title VII of the Civil Rights Act of 1964. The bill seeks to codify rescinded HHS guidelines. Rescinded, it's no longer active. That forced hospitals and emergency room physicians, in violation of the rights of conscience and Hippocratic oaths, to commit and complete induced abortions. All hospitals in Maryland already comply with the federal EMTALA statute itself. We're not talking about the actual statute. This was political guidance from Biden's HHS that has since been rescinded that the state seeks to codify. The FDA and state have created a wide-scale medical crisis for pregnant women in Maryland due to the reckless deregulation of abortion drugs. More than 11% of women experience serious medical complications. This has caused hospital emergency room admissions to increase by 500% to treat these women suffering from abortion complications. We already heard from one of the delegates how our ER wait times are the worst in the country. This is overwhelming our ERs with botched abortions. So this is a bill before this committee. There was a bill before this committee to require abortionists to have hospital admitting privileges. That bill didn't even get a vote from this committee. Instead of regulating abortion and abortion drugs to prevent injury and harm to patients, like all other forms of health care are regulated, this bill would shift the burden to hospitals and medical providers, charging them $50,000 if they don't comply, to clean up after the dangerous substandard abortion practices of the abortion industry, and in effect force unwilling providers to become part of the abortion workforce, and force hospitals to retain abortionists against their conscious rights. As a result, many healthcare providers were forced to leave the state, exacerbating our current medical scarcity and depriving women access to obstetrical care. We urge your unfavorable report. I'm happy to take questions.
I'm Dr. James Kelly. I'm a Maryland physician. I'm here speaking on behalf of the Nationwide Association of American Physicians and Surgeons in strong opposition to House Bill 372. All Maryland hospitals are compliant with the EMTALA rules. This bill does conflict with federal law. The laws that they discussed were from the Biden administration that are no longer the law. This bill removes conscience rights. This is why the bill is being introduced. It makes a change. People are saying there's no change, things will be the same. But this is the purpose of this bill. It's unconstitutional. It violates rights of conscience and religious freedom. It violates Title VII of the Civil Rights Act of 1964. And it pits hospitals against physicians. It tries to force medical staff to participate in abortions against their will. You cannot force people to do things that violate their constitutional rights, like performing abortions. Doctors will just quit the specialty. They'll leave the emergency room. They'll change specialties. They'll move out of the state. We already have a severe doctor shortage. This will create a government supercharged shortage of doctors. It will decrease care. It will decrease access. We already have a high ER wait. And that is what causes harm. This bill will cause more harm. It will abuse medical staff. It will decrease our access to care. The American Association of Physicians and Surgeons asks you to have an unfavorable report. I'm ready to take questions if anybody would like.
Thank you very much for your testimony. Are there any questions from the members for this panel? Delegate Kipke.
Thank you, Madam Chairman. I remain a little confused, and I come at this from the idea that, you know, anybody that presents at a ED with life-threatening conditions, I believe, should be cared for and stabilized. And so I'm confused. I'll ask the question of you, doctor, since I only play a doctor in committee. In real life, in a hospital, if somebody presents with life-threatening situation, if a woman presents, what happens now if they are, I guess you would call it having a chemical abortion, or versus what changes with this bill? So there's current practice today. I want to know what that is. And then what would the practice be after this bill is implemented? Thank you.
Doctors have for centuries always taken care of emergencies, and they will continue to do that. This bill, the purpose of this bill, removes the protections that physicians have. And in this case, one example would be they can be civilly sued, and also now they're no longer protected as employees of the hospital if they don't abort the baby. Under current law, they are not required to participate in the abortion. This removes the current conscience protections. And it even says here, except as provided in this article, the licensed hospital director may not be required, and then it goes on. So this gives the exception. Under current law, the doctors are not required to do that. Now, Biden added, as an executive order, I do believe, abortion into the code, but that was not part of EMTALA. EMTALA did not specifically and deliberately did not include abortion. Biden added that. That is no longer the law. That's been rescinded. This is the purpose of this bill, is to undo what the current administration has done by freeing up people's ability to not participate in abortions. Doctors, hospitals will be fined. So then the hospital will go after the physician, because every offense, the hospital can be fined $50,000. So then they're going to go after the doctor, which either means the doctors are going to be driven out of the emergency room, out of the state, have their total lives disrupted and ruined, because now the hospital is going to demand that they do the abortion. That's the whole point of this bill. There is no difference in what doctors have done or will do. We're always required to take care of the patient. Our job is to save lives, not take lives.
Thank you. And I just want to clarify the record before we take a question from Delegate Morgan, that on page 3 of the bill, it states, a hospital may not penalize or take other adverse action, including an action related to discharge, promotion, demotion, suspension, compensation, training opportunities, staff privileges, or admitting privileges against a treating healthcare provider if the provider refuses to authorize the transfer of a patient with an emergency pregnancy-related medical condition that has not been stabilized. A treating healthcare provider if the provider's treatment of the patient is consistent with the medical standards of care that in the provider's clinical judgment were necessary to stabilize the patient, or the hospital employee if the employee reports a violation of this section. I just want to clarify that.
But under 19, it says except as provided here in this bill. So all that is the way that it exists currently. The purpose of this bill is to undermine and eliminate those protections. That's why it says, and I quote, 19B, except as provided in this bill.
A licensed hospital director, or hospital governing board may not be required.
Except as provided in this bill.
Delegate Morgan.
Thank you, Madam Chair. I just wanted the questions for the doctor. So, good to see you. Thank you for your testimony. Thank you for clarifying some of these things that we're having some questions on. In your opinion, as a doctor, do you think this could lead to, you mentioned a couple things about being unconstitutional and violating your religious freedoms. Do you think this could lead to additional lawsuits?
100% against the hospital and against the physician. Currently, doctors feel under siege in Maryland because they may have some protections the way it exists now under Title VII of the 1964 Civil Rights Act. There are protections as an employee where the hospital may not go after the doctor because of conscience rights. This bill eliminates those protections. So certainly there's going to be more issues. The protections are already too thin for doctors that don't want to participate in this. They currently can be sued civilly. But in this case, now the hospital is being pitted. And the protection was, I think, and under some of these laws, the hospital there was a protection as long as there wasn't a burden. This creates a burden on the hospital. This is why that protection is removed, because then the hospital can say, we're being fined $50,000 every time a doctor doesn't participate. That, by definition, can be a burden. So then the protections that the physician has as of today will be removed because now this law burdens the hospital. So then the protections under Title VII will be voided. Does that make sense?
Thank you for clarifying.
So it goes after it. That's the whole point.
Thank you, Madam Chair.
Treatment doesn't change except with this bill. It forces people against their will to do what they don't want to do. It's unconstitutional.
Delegate Rosenberg.
The proponents say otherwise. If the committee were to write our Attorney General for advice of counsel regarding the effect of this bill on the existing conscience rights and the effect of this bill on any statutory or constitutional claim, would you accept that decision by the AG, or would you continue to say that the bill is unconstitutional?
We're all smart people here, and we all know what the word accept means, right?
I mean accept ACC, EPT.
Right, but the law as written says we have these protections except, which means you do not have these protections if this bill is passed.
So your answer is you would not accept ACC, EPT, a ruling of the attorney, an opinion from the Attorney General's office that
Not
is
unless
not
you could-
consistent with your opinion as a doctor.
It's with our definition of the word accept. That's the point of making an exception. When you make an exception, it doesn't apply,
Delegate Riley.
right?
Thank you, Madam Chair. Yeah, I guess this question is for Dr. Kelly. So I know you don't have the written testimony from other folks, and I don't see that the Maryland Catholic Conference is actually coming in person to speak with us. They are in opposition of this as well. And the letter, it struck me, you know, not funny, but it struck, you know, just stood out when I was reading their opposition. And they pointed out that, you know, the Catholic Conference is one of the largest, you know, social services provider in the state, just behind the state itself. So they do a lot of work. So, you know, I feel that you're very intelligent. You did a great testimony. What would you think, what is their main concern, would you think, being, you know, involved in a lot of social services things? They have hospitals, they have schools, and so on and so forth. What would you think their main concern is with this bill?
I don't speak for them, but assuming they're Catholic, assuming they're Christian, I would assume that they would not want Catholic hospitals to be destroyed or for their ER staff to be gutted or for people not to get care. I think what they would want is to protect our constitutional rights to freedom and our rights to conscience.
Okay. And freedom of religion.
Freedom of religion, right. The First Amendment to the Constitution, we're supposed to be the free state, and this takes away the freedom of people. And it puts, and then it jeopardizes the health and welfare of women and children.
Thank you.
Because when that happens, the treatment one of the delegates already said, we have one of the longest ER waits. It's really hard to recruit people, and this just makes it so untenable for someone who doesn't agree with doing abortions to even go into that field. And we're talking about nurses, we're talking about nurse techs, phlebotomists. You're not just talking about physicians, you're talking about everybody that works in the emergency room who wants to help people, who wants to treat patients. So all the emergency care will still be there as it currently is. It's just the difference is helping life versus taking life by demand of the government. We don't want the government to force us to do what is obviously against the Constitution.
Before I take Delegate Shalega, I just want to remind the body that this bill speaks to the responsibility of the hospitals, not the individuals. And the current protections for individual providers are still in the statute. Delegate Shalega.
Thank you, Madam Chair. Thank you for being here, Dr. Kelly. So Delegate Rosenberg was asking you about an Attorney General opinion, and I can understand why you'd be skeptical because we've seen some AG opinions that have been overturned here in Maryland. Have you, or how would you feel about obtaining an opinion, an attorney's opinion from a nationally recognized group that could opine on that and help from a legal standpoint, maybe Alliance Defending Freedom or somebody like that?
Sure. I'm always interested in learning as much as I can about any topic. And I think, more information would be very reasonable. But again, I know what the word accept means, right? We know what the word accept means. That's the whole point of this bill, is to create these exceptions to the rights that we currently enjoy in the free state.
Thank you.
Delegate Hill.
Thank you, and thank you for taking the time to come and testify, Doctor. I'm looking at an article, December 5th, 2025, from the Journal of the American Medical Association Health Forum, entitled Obstetric-Related Emergency Medical Treatments and Labor Act Violations and No Health Exception Bans, where they looked from 2018 to 2023 at all states with emergency room, at the emergency room presentation in obstetric and gynecologic care, comparing states that had abortion bans without health exceptions to those that held health exceptions. And I'm raising this because you talked about risk, and you talked about the conscientious objector provision that you say this bill would prohibit, which I disagree on. I don't think it does prohibit that. But you also talked about care to patients and wanting to make sure that that we weren't having more patients in trouble. And I think you, so this conclusion, I'm skimming down here really quick. So the results show, sorry, go right to the bottom here, and I apologize. Okay, the conclusions, I'm going down. They say that obstetric-related violations increased after states enacted abortion bans that lacked a meaningful health exception, rising by 1.18 obstetrical violations per state quarter. Compared with controls, the increase was largely associated with Texas, where they had no health exception, and they point out that they had mostly failure to screen violations, and they also had an increase in the 13% increase in the number of infants who died during the first year of life because because the care in the emergency rooms were
Delegate Hill,
compromised.
can you get to your
So
question,
the
please?
question is, how does that concern, and what I think the bill does is say, let's be sure that there's no confusion about what EMTALA requires. The advocates say it always required abortion. It wasn't explicitly stated because it was legal and it didn't have to be explicitly stated. But since Dobbs, it has to be explicitly stated that medical care, which includes abortion care, if it's necessary to stabilize, that it's still required. So how would you respond to the statistics that suggest that not making this clear actually will increase morbidity and mortality for infants as well as their mothers?
Well, it doesn't change what happens in Maryland. This is part of the Maryland Constitution now. Now, maybe Maryland law needs to clarify other definitions because, and also the definition of what medical certainty is. I didn't read that particular study, so I can't really comment on that. But I think one of the things that you said was the response was superior to states that have abortion like Maryland has legalized. So in your example, Maryland would be one of the best states according to that. So we already have accomplished that. And the Maryland Hospital Association reviewed, and all hospitals in Maryland are fully compliant or exceed the standards of EMTALA, which is the emergency regulations. So we've meted and we've exceeded. I mean, this is really just a response to what the Trump administration has done. And we really want you to rise above politics and put people first, put the pregnant mothers first, put children first. Let's not reduce access to emergency care and drive medical staff out of the state.
All right. Thank you. Thank you, Madam Chair.
Delegate Lopez.
Thank you, Madam Chair. My question is for the doctor. Thank you for your thoughtful testimony today. I'm going to read you a line that talks about the protections that doctors have. And you tell me if you feel like this is adequate enough, given the circumstances and the posture of the bill. A person may not be required to perform or participate in or refer to any source for any medical procedure that results in artificial insemination, sterilization, or termination of a pregnancy. Do you feel like that's an adequate protection?
You're reading current Maryland law?
Yes.
That's by first hearing, that sounds pretty reasonable.
Right? All right. Do you think, as of your reading of this bill, that changes this part of the code?
Yes.
How?
Because it says, except as provided. There is no other this bill adds nothing to medical care. It eliminates that right by charging the hospitals $50,000, which then makes the physician a liability to the hospital and a target for civil suit. That's the whole point of this bill. That's why you have the word except.
I think there's just a fundamental misreading of the legislation, but thank you.
Seeing no further questions, thank you to this panel. Thank you for your testimony.
Thank you very much.
And we do have one favorable virtual witness, Lexi White. And then we have one unfavorable panel of virtual. Do we have Lexi White? Okay. Ms. White, you can get started when you're ready.
Great, thank you. Good afternoon. Thank you, Madam Chair and committee members. My name is Lexi White, and I'm the Director of State Strategies with All Above All. We envision a world where the full spectrum of pregnancy-related and reproductive health care, including abortion care, is affordable, available, and supported for everyone who needs it. We strongly support House Bill 0372 because it strengthens protections that ensure pregnant patients in Maryland receive comprehensive, timely, and stabilizing care during life-threatening emergencies. Pregnancy-related emergencies, including ectopic pregnancy, miscarriage, complications, severe preeclampsia, hemorrhage, or infection, can escalate quickly. In these moments, delays in care or premature transport before a patient is stabilized can also result in irreversible harm. This includes organ damage, loss of future fertility, or worse, death. Sadly, these are still realities that disproportionately impact patients that are already impacted by bias and structural marginalization in healthcare settings. That includes Black women and women of color, and it includes rural communities. We've seen this play out time and time again across the country, sometimes with lethal consequences. Many pregnant patients already are traveling long distances for both routine care and access to emergency care in these life-threatening pregnancy-related situations. And when time-sensitive care is delayed or denied in a life-threatening situation, patients, might be forced into dangerous transfers before the emergency is stabilized, placing their lives at even greater risk. This legislation helps to ensure that patients first receive the stabilizing care where they are, including emergency abortion care as needed, rather than being put in harm's way because of access barriers. It ensures that hospitals can respond promptly based on medical judgment rather than on legal or institutional uncertainty, bias, or hesitation. We respectfully urge the committee's support of this legislation. Thank you.
Thank you for your testimony. Are there any questions from the members for this witness? I just had one question for you, given what we've heard today, and I know we're all trying to sort of wrap our arms around it. Would you say that this is a patient-centering, outcomes-driven bill? And would this give us clarity across our hospital systems as to how to center a pregnant patient who is in need of stabilizing emergency services?
Yes, I would answer yes.
Thank you very much. Thank you for your testimony. We do have two unfavorable virtual witnesses, so if we can bring up Rachel Nesmith and Elizabeth Mooney. Neither's in, okay. So just let the record show that Rachel Nesmith, and Elizabeth Mooney are not in the waiting room. Thank you very much all for your testimony today. This concludes the bill hearing on House Bill 372. We're going to go a little out of order because I am asking our amazing intern, Clara Pfefferkorn, to testify on the next bill, which is my bill. It is House Bill 422. This is the Public Health Expedited Partner Therapy, Bacterial Vaginosis in Licensed Certified Midwives bill. I read the title. That's actually the amendment. My apologies. And so, Clara, if you want to come up and bring your panel and start your testimony, and welcome Clara, our amazing intern, who is going to be testifying on the bill today.
Thank you, Madam Chair. Good afternoon, Madam Vice Chair and members of the Health Committee. For the record, my name is Clara Pfefferkorn. I'm the Legislative Fellow for the Health Committee and a student pursuing my master's degree in social work at the University of Maryland, Baltimore. Thank you for the opportunity to present House Bill 422 on behalf of Delegate Heather Bagnall, the Chair of the House Health Committee. HB 422 will amend the Maryland Health article to add bacterial vaginosis, BV, to the list of diagnoses for which expedited partner therapy may be used. EPT allows healthcare providers, when appropriate, to prescribe treatment for an intimate partner of a patient who has chlamydia, gonorrhea, and trichomoniasis without requiring a separate provider visit. This measure will expand the list of eligible diagnoses to include bacterial vaginosis. Globally, BV is one of the most common vaginal conditions among reproductive-aged women, affecting roughly 1 in 3 women worldwide. BV occurs when the number of protective lactobacilli bacteria decreases relative to other vaginal microbes. Recurrence rates for BV are alarmingly high, up to 66% within a year of treatment, and just one bout can require repeated rounds of antibiotics. Newly published research shows that treating male partners at the same time as the patient significantly reduces recurrence. A 2025 randomized controlled trial in the New England Journal of Medicine found that when male partners receive both oral and topical antimicrobial therapy along with the patient's treatment, BV recurrence fell from 63% to 35% in 12 weeks, compared to treating the patient alone. Based on this growing body of evidence, the American College of Obstetricians and Gynecologists now recommends considering concurrent partner therapy for patients with recurrent symptomatic BV. HB 422 does not create a new state program or mandate treatment. It simply expands the existing clinical practice that Maryland already uses for other conditions. Aligning Maryland law with the growing body of evidence supporting the use of EPT for BV will give clinicians the evidence-based tools they need to better serve their patients. Over time, reducing BV recurrence is likely to decrease repeat office visits, laboratory testing, and antibiotic use, resulting in savings for the patients and the healthcare system. I respectfully request a favorable report on House Bill 422, and I will now pass this over to my next panelist, Dr. Anna Powell.
Thank you.
Thank you.
Madam Chair, Vice Chair, members of the House Health Committee, thank you for the opportunity to testify on HB 422, which adds BV to the list of diagnoses allowed under expedited partner therapy. I'd also like to thank the sponsor for her leadership and support on this issue and women's health in general. My name is Dr. Anna Powell, and I'm here on behalf of Johns Hopkins University and Medicine to express our support for HB 422. I'm an associate professor of gynecology and obstetrics, a reproductive infectious disease specialist, and researcher who has been treating women with BV for the past 12 years. I co-authored the ACOG clinical practice update about BV partner treatment. As we heard, BV is an underestimated public health concern and increases a woman's risk for acquiring sexually transmitted infections, including HIV, as well as pregnancy complications such as preterm birth. This bill easily expands access to care and brings Maryland law in line with best practice. Maryland initially allowed expedited partner therapy in 2021, and as we mentioned, allows healthcare practitioners to treat a patient's sexual partner without physically seeing that person. This practice is currently allowed for chlamydia, gonorrhea, and trichomoniasis. In my clinical experience, and according to the trial that was just mentioned, the most recent research, expanding expedited partner therapy to include bacterial vaginosis may have a tremendous positive impact on lowering the rate of reoccurrence and thus have important public health implications. So Johns Hopkins is excited about the opportunity this bill creates to provide safe and effective care easily. Therefore, we urge a favorable report on HB 422.
Thank you for your testimony. And I believe that this is the first time you have testified before our committee. Is that correct?
Yes.
All right.
Yes.
Do we have any questions from the members?
Oh.
I have a question from Delegate Hutchinson.
I do have a real question. Thank you, Madam Chair. And sorry, as I've been following through this, at first I was like, why do we need to have legislation for this? So just bear with me that I'm understanding this. Partner A, Partner B. Partner A is diagnosed, and Partner A can go see the physician, be treated, and receive the antibiotic.
So let's say Partner A is a woman, right? So currently, a woman can go to her OBGYN or other healthcare practitioner to get a prescription for an antibiotic, but her partner cannot.
So B, what this really is helping B, Partner B, that Partner B can then also be
Correct.
receiving the medication
Yes.
without having to be seen?
Correct.
Okay, so
It reduces a barrier for example, an OBGYN provider to treat that patient's partner because otherwise they have to go to a primary care provider or the health department or somewhere. So there may be other barriers to treating that patient's partner. And we feel that adding BV to EPT would help reduce those barriers.
So is it assumptive or is it definitive that if Partner A has BV, that Partner B will definitively have it, or just preventative to make sure that Partner B doesn't?
There's pretty good evidence that if you have a heterosexual partnership, that the male partner can carry bacteria on themselves that may contribute to BV development. So based on that body of research, we're presuming that if one partner has it, the other partner probably also has it.
Okay, thank you. Thank you for the clarification.
Delegate Shalega.
Thank you. Thank you for being here. I have two questions. One, as a physician, are you worried about giving antibiotics out every time, I go or with my grandkids' kids to the doctor? There's great concern about overutilization of antibiotics.
Yeah, that's a good point. I will say that under current practice, so because BV has such a high reoccurrence rate, the rather large percentage of women that suffers from recurrent BV is already exposed to so many antibiotics. So if, based on the step-up trial from Australia, if we're able to treat a male partner and reduce the recurrence risk, then that ultimately that may result in fewer antibiotic prescriptions for the female partner.
Yeah, I was speaking more for the male partner that, giving antibiotics to
yes, if they decide to pursue the treatment, it would be an antibiotic exposure, but overall it would reduce antibiotic use for the female partner.
And finally, what if the female partner has multiple partners? Do you send her home with multiple prescriptions?
Yeah, so that's a good question. In the step-up trial from Australia, looked at monogamous relationships, so that would be a patient-provider discussion, but most likely that patient may not qualify for partner treatment.
So it would only apply to single partner relationships?
That's what the trial showed was effective. So we just don't have enough information to say whether it would be effective in multiple sexual partners.
Thank you.
Delegate Kaufman.
Yes, and I think I know the answer to this, but I just want to get it on the record. Without this medication, am I correct that the man, and just make it easier, can inadvertently give his wife, girlfriend, whoever, this condition again and again and again? Without the medication, you can give it over and over again, am I correct?
That's correct.
Okay, so what this bill does then is, what the medication does then rather is prevent reoccurrences. So you're one and done. Okay, thank you.
Delegate, I keep saying Delegate Ashanti. Delegate Martinez.
Thank you, Madam Chair. I have been Ashanti longer than I've been delegate, so that works as well. But to the panel, my question, following up on the gentlelady's questioning around multiple partners, is it that you just don't know because the study only focused on monogamous folks, or is it, in your professional opinion, that you wouldn't want to give someone that has multiple partners, I guess, the heads up? Because I'm just thinking about how people make certain risks, certain conditions are out there in the real world.
Yeah.
People have multiple partners. I just think we want to make sure this is inclusive in the bill so that we're not having someone with multiple partners.
I don't think we have to state it.
Got it. Okay, that's what I was making sure.
Yeah, I don't think, we don't outline it in the bill that I'm aware of. Yeah, that's just based on what the paper showed, but that's area for research for us.
Thank you.
Yeah.
And I just had a question, just a clarifying question. This is already existing practice. We're just adding
We're just adding the condition
to the conditions that are already covered by expedited partners. And I wanted to give you an opportunity also to speak to the amendments that have been proposed. I think all of the members have been provided the amendments through email.
I don't know if I have been. So I do apologize. If you could ask me more specific questions, I would be appreciative of that.
I believe that there might be two amendments that are being proposed by the sponsor, one of which adds certified midwives licensed under this program, and another one that just updates the language to be speaking more to modern language and destigmatizing. Isn't that so?
Yes.
All right, and we'll make sure that everyone has those amendments for subcommittee. Are there any further questions for this panel? Seeing none, thank you very much for your testimony. Well done to our amazing intern. We have two more favorable on this, two more on the favorable panel. We have Christine Crone and Robin Elliott. There are no unfavorables on this bill.
Good afternoon, members of the Health Committee. Thank you to Chair Bagnall for her leadership on this issue. My name is Christine Crone, again with the Maryland section of the American College of Obstetricians and Gynecologists. I just wanted to add that this bill is another bill that was on our Advocacy Day agenda on January 30th. We are very supportive, and we are also all right with the proposed sponsor amendments. Thank you.
Good afternoon, Robin Elliott here on behalf of the American College of Nurse Midwives. We are a big Me Too. Thank you.
Are there any questions from the members for this panel? Seeing none, thank you very much for your testimony. This concludes the hearing on House Bill 422. We're now going to go to House Bill 373, which is State Board of Dental Examiners Disciplinary Action and Unannounced Inspections. Delegate Kipke, if you'd like to approach the table and bring your panel, and you can get started whenever you're ready.
Pull one up from behind. Good afternoon, Madam Chairman, Vice Chairman, and members of the committee. I want to introduce you to Sophia Conrad, my intern, who will be telling you what the bill does. This is an update to a bill that was passed several years ago by this General Assembly, creating expanded function dental assistants.
Hello, Chairwoman Bagnall, Vice Chair Collison, and members of the committee. My name is Sophia Conrad, and I'm a public health science undergraduate student at the University of Maryland, and speaking on behalf of Delegate Kipke. Thank you for the opportunity to present House Bill 373, State Board of Dental Examiners, Disciplinary Action, and Unannounced Inspections. This bill accomplishes two things. First, it updates the name of existing Centers for Disease Control and Prevention, CDC publication, and it adds an important second publication. Last, the board lacks disciplinary action against the two newly created EFDA expanded function dental assistants. I would like to note that according to the fiscal note, the changes can be handled with existing budgeted resources. I ask you for your favorable consideration. Thank you.
Thank you, Madam Chair and members of the committee, for so graciously allowing this testimony in support of House Bill 373, State Board of Dental Examiners, Disciplinary Action, and Unannounced Inspections. My name is Dr. Leslie Grant. I'm a general dentist and speech and language pathologist. Currently, I am serving in the 4th year of my second and final term on the Maryland State Board of Dental Examiners, and I have chaired the board's Infection Control and Biosafety Committee for several years, and would like to request your support of a significant semantic change this bill offers that brings infection control language up to date and commensurate with Centers for Disease Control guidance. Presently, our regulations reference the term universal precautions. That term was replaced with the terminology of standard precautions around 1996. Standard precautions expand the concept of protection from risks associated with disease transmission. Universal precautions primarily included bloodborne pathogens and focused on healthcare workers' safety. The current terminology of standard precautions includes not only bloodborne pathogens, but also incorporates respiratory or airborne microorganism transmission and expands safety protections to healthcare workers, but also to patients and other contacts. The use of the term universal precautions is outdated, inappropriate, and misleading. When quoting our regulations when I give presentations, I have to resort to adding the term standard precautions in brackets, as well as an explanation to attendees
to make certain they're accurately informed. I again thank the committee for your consideration. I do support the disciplinary aspects of House Bill 373. However, it is important to me to offer this clarification and explanation as to the significance of incorporating this change in language to standard precautions, and I request your favorable support of House Bill 373. Thank you so much.
Thank you, Madam Chairs Bagnall and Cullison, and thank you, Delegate Kipke, for sponsoring House Bill 373, as well as the esteemed members of the Health Committee. My name is Deborah Carty. I am a member of the Maryland State Board of Dental Examiners. I am the chair of the Legislative Action Committee, and I'm a registered dental hygienist. This bill, as Sophia eloquently and Dr. Grant stated, adds one publication and changes the name of another publication. Both of these publications are used by the board very regularly when we do CDC inspections, and we also refer to them in our reports of CDC violations. So the statutory language needs to be updated to be current and relevant. Secondly, the board lacks disciplinary action against the newly created expanded function dental assistant, referred to as EFDA. Most dental assistants in Maryland are on-the-job trained. This statutory change does not affect them in any way. The EFDA requires specialized training and certification in which they provide direct patient care. In fact, they can now perform 4 direct patient care functions that were formerly only performed by a licensed dentist or a licensed dental hygienist. With increased responsibility in healthcare requires professional accountability. The board is the regulatory authority charged with providing the health, safety, and welfare of Maryland citizens who receive dental care. All other licensed and certified dental professionals are subject to board disciplinary action, and this includes dental rad technologists who are dental assistants who have the additional responsibility of taking dental x-rays. Without the statutory change, an unprofessional or incompetent EFDA could move from office to office, avoiding any repercussions or discipline. Thank you for the opportunity to testify. I'll be happy to answer any questions, and we do look forward to a favorable report. Switch with me.
Good afternoon, Madam Chair Bagnall and committee members. My name is Dr. Shari Cohn, and I'm a dentist member representing the Maryland State Board of Dental Examiners. In this bill, the State Board is asking for 2 items. The first, to update the annotated code of Maryland to the correct name of the existing, quote, Center for Disease Control and Prevention's guidelines on universal precautions to the current name being used, quote, Center for Disease Control and Prevention's guidelines on standard precautions. In addition, it would like to add an additional publication entitled Center for Disease Control Prevention Guidelines for Infection Control in Dental Healthcare Settings. These 2 publications are appropriate for our regulations for infection control in the dental environment. This is only a wording change with reference to the documents, no other changes. Our second item is enabling the dental board to take action against expanded function dental assistants when warranted. In 2022, under House Bill 968, Health Operations Dental Assistants, 2 new licensure categories were created. The first, General Dental Duties Expanded Functions, and the second, Orthodontic Expanded Function Dental Assistants. However, in House Bill 968, it did not allow the dental board to take disciplinary action against those expanded functioning dental assistants who violate state laws or the board regulations. House Bill 573 and Senate Bill 792, which were introduced in 2025, did not have a disciplinary section at all. While a dentist is technically the lead administrator and responsible for all patient care treatment, the original House bill only allowed disciplinary action to be taken against the supervising dentist. This would technically allow an expanded function dental assistant to violate laws with no consequences. This could potentially cause harm to a patient in our state. As a state board, it is our job to protect the citizens of Maryland, and furthermore, all other licensees and certificate holders for the state board are subject to disciplinary action. So for these reasons, it was a mistake in the original bill, which we are trying to correct this omission. I ask you to vote favorably on House Bill 373. Thank you very much for your time. Any questions?
Do we have, Delegate Johnson?
Thank you, Madam Chair, and thank you, Delegate, for bringing the bill, because you know we're all about accountability and oversight. My question is, who's doing the inspections now, if anybody? And would you have the manpower to do the inspections, to keep up with them?
Thank you so very much for your question. Presently, the board utilizes individuals who have been trained and calibrated to perform our inspections, our unannounced inspections. As a matter of fact, we recently had, in November, a new calibration and have accepted applications for additional inspectors as well. We've established a process as well as training and including familiarity with our regulations. We use a standardized checklist for these unannounced inspections, and the inspectors' reports are presented to the board for review and determination as to whether or not there have been violations of the Dental Practice Act.
Follow up, Madam Chair.
And I would just like to add that anything we're looking for, I'm sorry.
Okay, so are these, so they're unannounced inspections. So currently, are they, is there a schedule, a time frame that you do them, or are they complaint-driven? How does that work?
Yes, the board cannot conduct an unannounced inspection without receiving a written and signed complaint. And I believe regulatory-wise, these unannounced inspections are restricted to infection control violations.
All right, thank you. Thank you, Madam Chair.
You're welcome.
Delegate Shalega, followed by Delegate Hill.
Thank you, Madam Chair. First, always good to see you, Dr. Grant.
Thank you.
She
Always
is my
good to see you as well.
constituent. I remember back when O'Malley was governor, the inspections for dental offices, and you may remember this, Dr. Grant, took a turn where they used to be, I'll say, friendly. You know, somebody had the wrong light bulb, was an anecdotal story I recall. The wrong light bulb and, you know, the light that shines down on you. And they, you know, before the inspection was friendly, like, oh, Dr. Grant, you have that light bulb's not right. Can you please change it? And it turned to, oh, that's wrong. Here's a $50 fine. So, you know, that would be my concern. How can you address that these inspections will not turn into moneymakers?
Thank you for your question, and always a pleasure over the many years in many capacities, Delegate Shalega, to be here. And I would respond in that, to my knowledge, again, in unannounced inspections for infection control have been complaint-driven. There is just to kind of briefly, if I may, review the disciplinary process. The board receives complaints. There is a complaint review committee that receives redacted complaints, so we don't know who the respondent is, and makes a determination that there may be significant violations. Infection control violations are considered imminent harm, as would be impairment, inappropriate contact, physical contact. Those are considered imminent harm cases and are categorized typically complaints rather as Category 1. Upon review and approval by the board, a system is put into place, and for infection control violations, unannounced inspections occur. The unannounced inspection is not necessarily unfriendly. There is a right of entry into dental offices. There is a checklist. The checklist is a standard and same checklist for infection control violations that is used in all of the offices. Interaction, we must interact with the staff, or the inspector must interact with the staff and the proprietor, the dentist, and the dentists who are on site, because there are questions that have to be asked and there are items that have to be checked, as well as there's information that needs to be procured, such as biohazardous waste manifest. So I would not say, I would say that for anyone who has an unannounced inspection, it is not a comfortable environment, but it is not an antagonistic environment. That is part of our training, that our inspectors are there to do a job. And remember, please, for everyone on the committee, this is rooted in patient safety and protection, and also the public, as well as the staff members who are present in the office. I hope that I answered your question.
It does. I think the difference between those inspections were those, and you may recall those because the dental, association was very active at that time. Those might have been Delegate Kipke, like Department of the Environment, or somebody that was in, not for this kind of, but patient safety that you were talking about.
If I may, there are some requirements from the Maryland Department of the Environment that they have some requirements as well regarding radiation safety. And that is totally not related to the Board of Dentistry.
This is a different, yes. Thank you, Madam Chair. Thank you.
Delegate Hill.
Yes, thank you, Delegate Kipke, for another wonderful bill. And I wanted to say hello to Dr. Grant. It's good seeing you again. And the question is, one of the other witnesses wanted to add something to the answer, and I would like them to go ahead and add what they were going to say.
Yeah, thank you very much. I appreciate that, Delegate Hill. I did want to say that everything that we do inspect is on our website, completely transparent. So any office knows what they should be doing before we even go there. As Dr. Grant said, it's all about our patient safety. This bill that we're talking about, it has nothing really to do with the unannounced inspections. That's all already part of other bills. We're just asking that the expanded dental functioning assistants abide by the same rules as every other licensee. That's all.
Thank you.
Thank you very much.
Thank you. And Delegate Hill asked my question. So seeing no other questions, thank you very much for your testimony. I do have one favorable panel and one unfavorable. So Dan Doherty, if you want to come to the table, and you can get started whenever you're ready.
Thank you, Madam Chair, Madam Vice Chair, members of the Health Committee. Feels a little funny just to say health after all the years of health occupations. I'm Dan Doherty on behalf of the Maryland State Dental Association in strong support of House Bill 373. It is expanding the disciplinary authority of the board to the expanded function dental assistants under the bill that actually Delegate Kipke sponsored in 2022 and was passed by the General Assembly. You might ask, why are we focusing on dental assistants? Well, the dentist is the one in charge. He or she should be the first one that has to answer for any violation, and that was included in the original bill. It allowed for discipline of a dentist who allowed dental assistants to assist in the practice of dentistry in an unauthorized manner in violation of the regulations adopted by the board, without specifically instructing the dental assistants to perform an intraoral procedure that the certified assistant is authorized to perform, or failing to provide direct supervision of a dental assistant. So that's already in the law, as it should be. This merely gets the board to look at the dental assistant and see if the violation is their doing, the dentist doing, or a combination. I'm sorry Delegate Saliga left, but it was, what she was talking about was a problem with the Department of the Environment. And they had reached an agreement years before about what they would review and how they would act, and then all of a sudden changed it. And we had to get a bill passed to put it back to what the original agreement was. So it was the Department of the Environment, not the State Board of Dental Examiners. With that, I would urge a favorable report.
Thank you very much for your testimony. Do we have any questions for this witness? Seeing none, thank you very much.
Thank you very much.
We do have one unfavorable, Daniel Brannian. You can go ahead and come to the table and get started when you're ready.
Good afternoon, Madam Chair, Madam Vice Chair, and members of the committee. My name is Danielle Varanian, and I'm an attorney who represents licensees before the Maryland State Board of Dental Examiners, including dentists and dental hygienists. I'm urging an unfavorable report on House Bill 373 for two main reasons. First, the bill expands the board's authority to conduct unannounced inspections for CDC infection control issues, which fits within MOSH, which is Maryland's OSHA. And second, because the bill also attempts to put the onus on a dentist to ensure that an expanded function dental assistant is certified when it is not on the dentist for other dental assistants. These changes are particularly concerning because I have represented dentists before this board where they have conducted these types of unannounced inspections and used them as the basis to summarily suspend certain dentists from practice and then weaponize the current language already in the statute. So to Delegate Schlegel's point, they are not friendly. They do not result in a fine. They result in summary suspensions. More than that, this also raises the question about why it's necessary to add a provision that states that if a dentist employs, supervises, or uses the services of an expanded function dental assistant who isn't certified, the board can discipline the dentist. To Mr. Doherty's point, the language he's referring to is in Section 38 of the statute, just above the language here. And what that language does is focus on what it is that the dentist has done. If the dentist has put a dental assistant in a position to practice in an incompetent manner, then the dentist is on the hook. That's not what this language says, though. This language says is if you employ them or supervise them, then you're on the hook. We should not be expanding the authority of a board that has a consistent track record of taking a mile when given an inch, especially when this board is not handling what's within its purview already, unless it happens to be in the infection control space. I represent a dentist who owns a practice in Maryland who terminated a doctor that he employed because that dentist sexually assaulted his dental assistant. It's been 6 years, and this board has done nothing. And if that isn't Maryland patient safety, if that isn't imminent harm, I don't know what is. So to expand this board's authority in any way is dangerous. Thank you, and I urge an unfavorable report.
Are there questions for this witness? Delegate Johnson.
Thank you, Madam Chair. So if the dentist is the boss, he's doing the hiring and firing, and if it's his practice, who is the ultimate authority in that office? And then who should be held accountable? And should not the dentist be making sure that everything is going according to law and the safety guidance? So who would be the ultimate authority?
From a licensure and certification standpoint, the person who holds the license should make sure that that license or certification is up to date. But if there were language in here, like in section 38, which is just above on page 2, just above the changed language or added language on 39, if you look there, delegate, it says that you can punish a dentist if that dentist allows a dental assistant to assist in the practice of dentistry in an unauthorized manner in violation of this title. Number 2, without specifically instructing the certified dental assistant to perform an intraoral procedure that the certified dental assistant is authorized to perform, or failing to provide direct supervision of the dentist. This is an anomaly, what we've added here. What this language adds is employs, supervises, or uses the services of an individual, and it harkens back to language that we spent years fighting over in this committee when it was HGO about different practice models. So it's inconsistent with how the board treats a dental assistant as opposed to an expanded function dental assistant.
Follow-up. But isn't everybody in that office working under the supervision and responsibility of the dentist?
Yes, delegate.
Okay, thank you.
Delegate Hutchinson.
Thank you, Madam Chair. Hi, Danielle, good to see you.
Good to see you.
Actually, a simple question. I just missed it at the beginning because it's not listed in the witness list. Exactly who are you representing?
So I represent Heartland Dental, which is a dental support organization.
Okay, so I got it. I understand. That's all I need to know. Thank you.
Delegate Hill.
Thank you. I guess I'm misreading the bill. I see in section D, it talks about reprimanding the dental assistant, and where you're talking about reprimanding the dentist, it seems like it's for a dentist who employs, supervises, or uses the services of an individual as an expanded functional dental assistant who is not certified. So that would be they're hiring someone in their office without checking the certification. Why should that not be something the dentist is held liable for?
Because, Delegate Hill, it's inconsistent with how the code is written with respect to regular dental assistants. It's putting the onus on the dentist. So let's say, for example, the expanded function dental assistant, their certification lapses. The dentist did what the dentist was supposed to do in hiring them and vetting them properly. The dentist doesn't know, though, that the certification lapsed. Here, the onus is not on the dentist. It's on, the onus is on the dentist, not the expanded function dental assistant. It's not for actions of the dentist. Simply employing someone is now actionable.
May I follow up? So my understanding is if you're hiring people, and this is also from personal experience, that part of your obligations not only is to keep your certification up, but anyone you're hiring is to turn their renewed certification in. If it lapses, they're to notify you, and if you don't, that's the defense, is it wasn't supposed to expire to this amount of time, it lapsed, or it was revoked and I wasn't told, that's it. So they are responsible for knowing not just that they were certified at the time of hiring, but that they are recertified, and otherwise they're not allowed to touch the patients. So why am I wrong about that?
So I'm not sure that I fully understand your question. I'm drawing a distinction between how the code is proposing we change the disciplinary action for a dentist. There's a distinction being drawn between a dentist who employs a dental assistant versus just the expanded function dental
Okay, so if we amended this bill and said the same thing, if they employ a dental assistant who is not certified, they would also have liability. That would be okay.
I don't necessarily think that would be okay. What I'm saying is, though, why is there a distinction with the expanded function dental assistants? Why isn't the language the same as the dental assistants?
Okay, thank you.
Delegate Alston.
Thank you, Madam Chair. When you get an opportunity, can you please provide the name and information of the person that sexually assaulted a dentist assistant to my office, if you have it?
It's not a question of whether I have it. It's a question of, there was a lawsuit involved, and I represented the owner of the practice, so there's privilege considerations. But let me figure out how I can do that without violating any privilege.
It was a public lawsuit?
There was a public lawsuit,
So
Delegate.
it's public record?
There is a public record.
So you could send me the case number?
I could.
That would be great. Thank you.
Seeing no further questions, thank you very much for your testimony. I do want to continue to pursue that because that is a concerning charge that was made on the public record. So I would like to, have a conversation with the dental boards as well. That concludes the hearing on this bill, on House Bill 373, and we are now going to go to House Bill 448, Health Facilities, Certified Recovery Residences, Unannounced Inspections. Delegate Rosenberg, if you want to approach the table and bring your panel, and you can get started when you're ready. All right, I will tell you who I have listed because I don't have the panel specified, but I have Felicia Porter, Lauren Graziano are your favorables in person. Then I have a panel of favorable with amendment and a virtual favorable. My virtual favorable are Nancy Rosen-Cohen and Thomas Higdon, so let me know if they're part of your panel as well.
Thank you, Madam Chair, Madam Vice Chair, and members of the Health Committee. I'm sure all of us have had to deal with community reaction, our constituents' reaction to the announcement that a care facility providing in-community care for people with drug issues or alcohol issues is going to be located in a neighborhood in your district, that it is not welcomed by the neighbors. They complain that there are too many such facilities in their district. In their neighborhood, why aren't there facilities in another? Why aren't they equitably distributed across the district, the legislative district? I became, and that is, as you might guess, I love this job, but that's not one of the parts that I like, is working with the community to try and prevent care that, as public policy, we, and myself included obviously, have decided is the appropriate public policy to get people out of institutions and into the community where they are, with the right care, are better able to address their problem. Two events occurred which I think have resulted in the department's support for the bill and the extent of the public support that you will hear from as part of the testimony. One is the coverage of one particular house that was provided as a facility by the for opioid treatment in response to that recent epidemic. That there was newspaper coverage in the Banner jointly with the New York Times of the inferior, unsafe, unhealthy facilities that a fair number of folks were staying in. And I don't know if Ms. Sabatini is here or testifying remotely today, but she told me this Monday the story of her son who overdosed while staying in one of these facilities, and she lost him. And her story is far more effective than anything I will say today in terms of the need to address this problem through House Bill 448 as introduced or amended. Second part is that I became aware, and we did this as a district effort, that the State Department of Health does evaluations of these facilities. And that, if it's a poor evaluation, that gives the community grounds for raising concerns about the continued operation of the facility in the community. So what this bill proposes is in addition to the existing review of how a facility is being run, that there be 2 annual unannounced inspections by the Department of Health. That raises a fiscal note, and I welcome the work of the committee and the relevant subcommittee to amend the bill to get the fiscal note down below 100,000, which is what our goal is this session. I think there are reasonable ways to do that. There is also a special source of funds to draw upon, the opioid restitution fund. Whether that, under our rules, doesn't count towards the $100,000 ceiling, I don't know, but we can inquire and find out. Bottom line for me, I think what this bill does is give the community, the health department, and most importantly, the people being served, people with addictions being served by the health department, a better way than we have currently of learning if the facility is providing proper care and then taking the appropriate action in light of the department's report. This would no longer be not in my backyard policymaking, but policymaking based on a professional evaluation of the care that is being provided. I look forward to working with this committee and the subcommittee for a favorable with amendments to deal with the fiscal note report. Thank you very much.
Thank you for your testimony. Are there any questions for this witness? Delegate Hill.
Thank you very much. Thank you for the bill, Delegate. The Recovery Housing and Treatment Corrections Coalition, or Centers Coalition, offers some amendments. Did you have a chance to entertain those, or, okay?
No, I have not.
All right, so they offer some amendments. And then the second part of the question is, you specify that if there are deficiencies found on these pop-up inspections, that they should be notified and then have a month. We heard testimony in a briefing about different community facilities that often
Thank you.
yeah, the failures, often the deficiencies have to do with capital issues rather than operational. And so I guess my question is, if the deficiency has to do with a leak in the window or something like that, of the facility's physical things, do you still feel that they should have just a month to respond, or you want to, you would give the secretary still that kind of leeway?
I am flexible. The goal here is, and a valid question, the goal here is to get the property improved and the care provided improved. And that's paramount, not the number or the speed of the orders.
All right, thank
of
you.
the evaluations. Thank you.
Vice Chair Cullison.
Thank you, Madam Chair. And thank you, Delegate, for the bill. I am, maybe my packet is not complete, but I am not seeing anything from the Health Department. Have you had conversations with them about this and what their capacity is, what, if anything, they're currently doing?
I believe we've had conversations, positive conversations. I would say is a negative way of putting it, not necessarily this department, but it has been known to happen that a department will kill the bill with a fiscal note. That did not happen here. The department wants to work with us, is my clear sense here. And I think we should open the door for that to happen.
Okay, thank you. Thank you, Madam Chair.
Delegate Ross.
Thank you, Madam Chair. I too did want to see something in writing that tells us the department's perspective on this and their support for the bill. If you can secure that, that would be helpful. Thank you for this. I have dealt with this a month or two ago with the community that, as you described, there is a lot of aversion to having these kinds of facilities in the backyard of some of our communities. And in this particular case, it was going to be just steps away from an elementary school. So I did deal with it, and they were at the time, I only knew about it because they were pursuing a zoning permit exemption to do a 3.5 facility. I think they were a 3.3 outpatient. And they were turning the facility into an overnight, which requires a different, it's a different zoning requirement. So I do think this bill would help communities like that know that there's some oversight, continued oversight through these random, I assume will be random inspections. So thank you for that. My question, though, and thank you for sitting through my context around this question, it's really to, and again, Delegate Hill, I'm channeling my inner Delegate Hill right now. I didn't mean to do that. I, too, had a question about this 30-day time period to address the issue. Not all deficiencies are equal. I think there are some deficiencies that you can go in and see that are so egregious and could put the community at risk that I don't want to give them 30 days to fix it. So could you see an amendment around that could consider the different kinds of deficiencies that one might see during an inspection?
I would assume that somewhere in the code, we have that kind of gradation in terms of the time that an agency has to respond to an emergency and the time that it has to respond to a non-emergency problem. I would think that's somewhere in the code, but that's research for distinguished committee counsel to do, not, I would think.
I
We
would
can do
like
that
to know,
jointly.
yeah, if that's some kind of a minimum, is that what you're saying, that maybe?
I am very open to, I am very flexible. I want to have something, I hope we can come out of this with a bill that will enhance the evaluation of these facilities and in an appropriate way, and the communities feeling much more at ease with these facilities, and not just heretofore, any discussion ends with these folks are disabled and therefore protected under the federal civil rights law. You can't do anything. That's been the situation for quite some time. And this bill, as it can be amended, gives us the opportunity to be consistent with the civil rights law and beneficial to both the people in the facility and the neighbors of the facility. That possibility is there with our further work.
Okay. Yes, I'd love to know if there was a 30-day minimum for emergency situations, not for now, but for later. I mean, if they walk into a facility and it has, the doors are off the hinges and there's no security protocols, I wouldn't want to give them a month to fix it. It should be fixed much sooner than that, so thank you.
Delegate Gazzoni.
Thank you, Madam Chair. Just quickly for Delegate Ross, I was looking at the fiscal note, and there's a paragraph in there that says a certificate of compliance.
Can you speak closer to your mic?
Yep, sorry.
Thank you.
A certificate, the fiscal note indicates that a certificate of compliance is valid for a year from the date of issuance. The credentialing entity may revoke their certificate of compliance if the credentialing entity finds that the recovery residence is not in compliance with requirements. So it sounds like they could kind of pull it quickly if that was the situation. My question actually was around, also around the fiscal note, because the fiscal note indicates that MDH advised that this task would require 11 additional staff, but then goes on to say that DLS thinks that they could do it for less. So I'm just curious about trying to thread the needle on that, and if MDH is comfortable with DLS's idea that they could do it with significantly fewer additional people.
Well, I believe that the fiscal note is now in the hands of DLS in terms of when a bill is amended, if it has a fiscal effect, DLS will revise the fiscal note. So the fact that DLS is saying that the cost is less than the department is a positive sign.
Okay.
But I believe we can consult with DLS along the way to make sure that, I believe, that the amended bill, the fiscal note would be under 100,000.
Yeah, to clarify, that the fiscal note reflects what DLS believes it would cost, not necessarily what MDH. Correct.
Going to be more than that than we are it's just a harder thing.
Well, and I think
the numbers will go up, not down.
Given the fiscal note, we would have to get a review of the amended bill. So we are going to send this to subcommittee. It sounds like you are receptive to amending the bill because obviously we want high standards. If we were to pass the bill as drafted, it would be 30 days because this would supersede, existing practice. However, we can also amend the bill and define what we want that to look like. So I'm going to ask that, that our sponsor work with the department as well, since they didn't weigh in on this. And then I know we have some additional testimony, favorable with amendment, and there are also some proposed amendments within our testimony. So thank you very much for your testimony. And do I have Felicia Porter and Lauren Graziano? We have 2 favorables, 3 favorable with amendments, and then we'll go to our favorable virtual testimony.
Good afternoon again, Madam Chair and members of the committee. Lauren Graziano, for the record, here on behalf of Gaudensia. We are here today in support of HB 448. You have my written testimony. I won't repeat it here, but one point I raise in it that I'd like to highlight, and the discussion is teed up very nicely for me, is that one of the greatest tragedies, I think, when we have service providers who are not operating ethically and responsibly is the erosion of community trust, specifically trust in the efficacy of the services we're providing to people in recovery, which then I think further perpetuates the stigma against people in recovery. And so I think the bill provides a really simple and reasonable solution to policing, we've heard this term a lot today, bad actors in this space. And to that end, we would ask the committee for a favorable report with the understanding that if it is the will of the body to amend the bill, we stand ready to be a technical resource as well. Thank you.
Thank you for your testimony. Do we have any questions for this witness? Seeing none, I just want to call one more time Felicia Porter to make sure that I have not missed her. Thank you very much. I do have 2 favorable with amendments in person, Teresa Hessler, Dan Rabbit, 3, and Deborah Santini.
I wasn't first on the list, but shall I just get to it? All right. Great to see everyone. Chair Bagnall, Vice Chair Collison, members of the Health Committee. My name is Dan Rabbit. I'm the Policy Director for Behavioral Health System Baltimore. We are the local behavioral health authority in Baltimore City. We work closely with the department for oversight and compliance for the range of mental health and substance use services in Baltimore. We support the intent of this bill and offered some amendments to try to help with feasibility and implementation. You have my written testimony, but I'll just highlight a couple, like the main changes that we proposed. One is to allow the department to work with a designee, such as the local behavioral health authorities, to accomplish this. LBHAs generally do more inspections of certain types of providers than the department itself does. So we think that would help with capacity. We also propose to do fewer unannounced inspections. We propose 1 per certification period rather than 2 a year, which we think would also reduce the fiscal note but would still be a frequent enough unannounced inspection to keep these providers honest and make sure that they are meeting a high standard. And lastly, we included some information or some language to clarify that it's not just like a building inspection, but it's an inspection of staffing, services, and medication policies. We have heard a lot around recovery residences not allowing people to stay in their homes if they take medication for opioid use disorder, like buprenorphine. So we'd like that to be a part of the inspection process. I did just want to, I know my time is coming up, but I wanted to clarify quickly that this is only about recovery residences. Recovery residences kind of exist outside the normal licensure process. There is not a separate accrediting body outside of the state that certifies recovery residences. And so having a statutory requirement to do a higher level of oversight would be appropriate because these entities don't receive the same level of oversight as other licensed behavioral health providers in the public behavioral health system. So those are our comments, and happy to answer any questions.
Madam Chair, thank you for the information. How long is a certificate term, or the term you're speaking about?
I think it is no more than 2 years, but is usually 1 year. And under that certification process, it's the Department of Health, the Maryland Certification of Recovery Residences, MCOR, does the certification, and they're supposed to do 1 inspection already per the certification period. And our amendment would say also do 1 unannounced inspection per certification period.
All right, thank you. Thank you, Madam Chair.
Thank you, and I just was informed Teresa Hessler's in the Senate, so she is on her way, but she is here testifying today. I just had 2 questions for you, because you spoke to the ability of the local behavioral health authorities to assist with this. What is their capacity in terms of training for those inspections, and would that require a further statutory change to give them the authority to do those inspections?
I don't believe it would require any further statutory change. Local behavioral health authorities are in statute as like the local arm of the department already. And in regulation, it frequently says the department or their designee, and that is generally referring to the LBHA or another similar local entity. In terms of training, I mean, if the department were to designate all of it, it would require more resources, and then the locals could handle, I think, the training and the hiring. But we're more thinking of this like more of a partnership. And so similar to what was said in the fiscal note, that the existing inspectors that the department has can help to reduce like administrative costs, looping in the locals and having them as a partner in this could also potentially lower the administrative burden.
Thank you very much. And just a follow-up, because I know we're trying to, tread carefully, because this is an environment where stigma still looms, but we also want to make sure that we have a high standard of care. Do you see the local behavioral health authorities as a welcome partner in this work, so it wouldn't cause friction within the recovery community?
Yeah, I would think so. I mean, BHSB, like I was saying, recovery residences they're a unique provider type. So with the regular like residential substance use programs and intensive outpatient programs and opioid treatment programs, mental health programs, BHSB is already like the local kind of representative of BHA and serve as the local point of contact for all those other provider types. Recovery residences are different. They're not technically treatment facilities. They're housing. They're like sober living housing. And so they exist in a slightly different space, but we already respond to any complaints that our jurisdiction receives about recovery residences. And, we agree with the delegate that, the right response to concerns around not in my backyard or stigma is that is not to restrict these providers, but to ensure high quality of these providers. And that's what we would want to do, and that's the approach that we take.
Thank you very much. Oh, Delegate Hill.
And it's good seeing you. Can you address the two well-publicized cases? If they're already sort of being followed, we're already responding to complaints, what happened?
Yeah, but with PHA Healthcare, I think that was the main one. The complaint process requires somebody to report something, and we receive dozens of complaints every year, but like not a ton. And so I think some gaps that could have been tightened is like making sure that the patients and the program participants are aware of the complaint process. I don't know that always happens with all providers. We never received any complaints.
So you had no
them.
complaints about those two
Correct.
situations?
Yeah, we didn't receive any complaints. The inspection process, so PHA Healthcare did operate recovery residences. And, I think what this bill does is unannounced inspections. So I think if the inspection is announced and, I can't speak for kind of like how the inspections went, but those inspections aren't done by the local behavioral health authorities today. But that's like another gap is how rigorous are those inspections. And that was also during Optum, the Medicaid ASO that had a lot of concerns, and wasn't especially effective. And so maybe some data that could have, like some claims data or something that could have raised red flags were missed. So hopefully we can kind of tighten up all of that going forward.
Thank you very much. Seeing no further questions, thank you very much for your testimony. I do have two favorable virtual witnesses, Nancy Rosen-Cohen and Thomas Higdon. And Ms. Cohen, you can get started when you're ready.
Thank you. Good afternoon, distinguished members. I'm Dr. Nancy Rosen-Cohen, Executive Director of the National Council on Alcoholism and Drug Dependence for the state of Maryland. I strongly support House Bill 448. Unannounced inspections are really vital. Inspections themselves are vital, and unannounced are even more vital. Our consumers that enter these programs really need the support and the guidance. I really believe that anybody that enters a program like this really needs a recovery plan of care. And that plan of care should be adhered to, and the consumer should be part of it. We have some terrific programs, and then we have other programs that are just taking the consumer's money, and they're maybe just providing a room, and they're not providing the guidance and support they need. I spoke about a month ago to a person that had an inspection done, and the inspector was in her office in Baltimore City, and the program was in another county. So the inspection went, the staff person from the recovery residence was walking around with their iPad, showing them different rooms, showing them a client, or showing them the kitchen. This is not my idea of an inspection, and that is just really not acceptable. Inspections unannounced really are important. We want to serve our community. We want to help people. We want to get them into recovery residence with a plan of care, and then they move on into the community. So it's really important for the government to do their job. They are providing the financial support. So indeed, it's up to the government, the Department of Health, to provide the oversight. So I'm a strong believer in unannounced inspection. And I have to say, honestly, I'm a strong believer in inspection in itself. So it has to be done, and it's not being done. So I thank you for putting out this bill, and I appreciate the time.
Thank you very much for your testimony. If you can just stay on,
Sure.
so we can, for questions. Oh, no, Thomas Higdon is not. All right. Let the record reflect Thomas Higdon is not in the waiting room. Do we have any questions for this witness? Seeing none, thank you very much for your testimony.
Thank you,
for being here
Chairperson,
today.
and congratulations on your appointment.
Thank you.
Thank you. Bye.
I just want to ask one more time if we have Teresa Hessler or Deborah Santini. She's still in the center. Okay. Deborah Santini. All right. This concludes this hearing on House Bill 448. We are going to go to our last bill of the day, House Bill 374. This is State Acupuncture Board revisions. Delegate White Holland, if you want to approach the table, you can go ahead and bring your panel and get started when you're ready.
Hi, how are you? Good. All right, we're all set. All right. Good afternoon, Madam Chair and members of the Health Committee. For the record, I am Delegate Jennifer White Holland. Thank you for the opportunity to present HB 374 for your consideration. In my written testimony and from the testimony that you will hear will be a brief background about the Board of Acupuncture's role in regulating the practice of acupuncture and East Asian medicine in Maryland. In our committee, we have heard legislation related to the most widely recognized modality of this practice called acupuncture, which is the insertion of needles along meridians and acupoints to positively impact energy flow, a process which addresses a myriad of health conditions. Acupuncture and East Asian medicine is just one form of holistic medicine, a comprehensive, patient-centered, whole-person approach to healthcare that develops plans of care to treat body, mind, spirit, and emotions for the purpose of promoting healing and restoring overall health balance. In Maryland, multiple forms of holistic medicine require a license to practice. In East Asian medicine, manual therapy or body work is an umbrella term for the mind-body therapy that practitioners use to promote and optimize whole person healing and functioning. It includes forms of East Asian massage, Tui Na, as well as cupping, scraping, gua sha, and applying the non-needle therapeutic touch and pressure synonymous with acupuncture, which is known as acupressure. It is also important to highlight that acupressure is often used in the practice of East Asian medicine when providing care for pediatric and geriatric populations and/or with any condition or in any situation in which the use of needles are inadvisable. Acupressure is identical to acupuncture in that it relies on the system of East Asian medical principles and theories indicating the application to pressure to mapped areas on meridians and acupoints. Applying pressure to mapped areas positively impacts energy flow and remedies or treats health conditions. This is one of the cornerstones taught and reinforced in acupuncture schools or East Asian medical schools across the country. It is integral to the graduate level curricula and standard to the tenets that are included on the national board exams for acupuncturists. As such, it is imperative that acupressure be included solely under the scope of practicing the system of East Asian medicine. And so, without further bearing the lead, the proposal before you is not the board's attempt to expand its scope, nor is it to restrict or prohibit access to holistic medicine. Rather, it is to ensure that Marylanders have access to quality care from qualified practitioners based on proven standards of care and established practice law. As such, this bill accomplishes four things. First, it updates the practice law to make clear that manual therapy, which is a dated term, is body work, and that acupressure is just one form of East Asian body work and therefore requires a license to advertise and practice legally. Secondly, it is also to prevent bad actors from using acupressure as a business model that does not require state licensure via the boards of acupuncture and massage therapy examiners. Third, it also, to further it ensures that employees who are often misled to believe that they have paid for training and are now licensed healthcare practitioners, It ensures that there is a prevention of bad actors from using acupressure as a business model that can exploit both employees and customers. Employees that may be additionally be victims of sex trafficking and slave labor, customers that pay for services believing they are being treated by qualified practitioners. And fourth, to further the Board of Acupuncture's ability to enforce practice law by adding sanctions for those that aid and abet the unlicensed practice of acupuncture in East Asia medicine. These sanctions go further, following the example of fellow health occupations boards, by providing criminal penalties that afford law enforcement the ability to charge bad actors with a misdemeanor on the first offense and a felony on subsequent offenses. And so this board has not made this decision in a vacuum, as this proposal was brought forth after completing investigations in collaboration with the Board of Massage Therapy Examiners, elected officials, county task forces, as well as law enforcement. And so we are aware of the amendments that are also in your floor system, and that will be offered by some of the witnesses that you will hear from. I am also offering 2 sponsor amendments that may speak to some of the opposition's concerns that were elevated in testimony, which was previously shared with council and you recently received. And so as the culture and expectation of this committee, we do look forward to working collaboratively in and outside of subcommittee to work out any issues. And so HB 374 is a necessary step in protecting Marylanders and ensuring that every person practicing bodywork in our state is properly licensed and held to professional standards. I respectfully request a favorable report. Thank you for your time. Go ahead.
Good afternoon, Chair Bagnall, Vice Chair Cullison, committee members. I am Tiffany Smith-Williams, the Executive Director for the Board of Acupuncture. And HB 374, we are requesting a favorable report. Again, it's a public safety issue that we are mandated to address because our mission is to protect the public. It makes clear that the board has the authority to regulate East Asian medicine and body work, as well as acupuncture needles, which is the most popular form of East Asian medicine that we regulate. And it allows us to enforce sanctions and law enforcement to enforce sanctions on people who aid and abet the unlicensed practice of acupuncture. This bill does not change the board's existing scope. Manual therapy has been in our law from the beginning since 1994, and I would argue since our previous existence under the physicians in 1982. And it does not infringe upon any other practitioner's ability to practice manual therapy for which they may be licensed. I know there is testimony from the Physical Therapy Board as well as the Chiropractic Board. I have chatted with their lobby and followed up with them to let them know that we're not trying to take over manual therapy. We're just making sure the public understands that we do regulate manual therapy. And we will be reaching out to chiropractors as well. We additionally addressed the practitioners who in times past were credentialed under a different environment, and one of the amendments you have addresses that it would not prevent them from continuing to practice and support themselves in their businesses. Again, manual therapy is under our law. There's no question about that, and that's what acupressure is. This is in part fueled by an institution that issues weekend certificates to unlicensed people as well as some licensed non-acupuncturists to say that they can perform acupressure, and it certainly just isn't a fact that they can do that without a license. And as mentioned before, we've had a collaboration with many parties, including reflexologists, as well as Montgomery County Council. Thank you.
Dr. Sharon?
Yes. Good afternoon, Honorable Chair, Vice Chair, members of the House Health Committee. Thank you for the opportunity to testify. I'm Dr. Sharon Jennings Rojas. I am an acupuncture and herbal medicine physician for almost 4 decades. I've worked in a variety of settings, including installations like Fort Belvoir, as well as Baltimore City Public Jail, as well as Howard County Detention Center. I have a myriad of things that I could say about this bill. For one, 100% support it. I'm here on behalf of the Maryland Acupuncture Board, where I serve as a professional member and as vice chair. As it impacts public health, the art of learning and healing in healthcare practices is their own healing modality in their own right. Many of us have witnessed bridges that are formed when different modalities of care come together. However, this situation where acupressure is practiced by unauthorized individuals who have either taken certification under unaccredited facilities or just poor actors that are using acupressure to service and illicit services at that, really does put Marylanders at risk. And not only Marylanders, but also the folks that have studied the system of medicine like myself with a terminal degree. But at the end of the day, if somebody else is practicing the medicine that I espouse to be healing and helping people on their healing journeys, it also is bad PR for us. And so more than anything, we want to make sure that our Maryland citizens are protected, free from any type of harm or danger. And we really would hope that you would support the passing of this bill. Thank you.
And I believe we have one virtual witness on your panel and then a virtual witness who's favorable. Is that correct?
Yes, just Dr. Gary is a
Dr.
part of
Gary,
our
if you want to
panel.
go ahead and unmute and start your testimony. Thank you.
Okay, sorry. Good afternoon, Madam Chair, Vice Chair, members of the House Health Committee. My name is Dr. Brandy Gary. I am the chair of the Maryland Board of Acupuncture and a professional member. I'm licensed as an acupuncturist in East Asian medicine in multiple states and nationally accredited. I studied in Asia as well as here in America. I'm a Montgomery County resident, female disabled Army vet, and a East Asian medicine business owner. My testimony is in support of House Bill 374. It clarifies that manual therapy is bodywork and acupressure and should be requiring licensure to practice. It's part of our foundation from our original beginnings. Manual therapy started during the Stone Age, and it was under East Asian medicine as the basis for all body work today. Needleless alternatives of acupuncture is acupressure, and that's a non-invasive treatment that adults and children as young as 3 weeks old can be treated with. If someone is improperly educated and not degreed and not trained in acupoint safety, they could be putting points or massaging points in a space on the body that's affecting another body part and could cause very bad problems, and they may not understand how to fight or fix the problem that they may have created because they don't understand the safety. An example of that is a point on the hand that if someone's pregnant, if you don't know that it could be contraindicated to use a point, it could potentially cause a miscarriage, and that would be terrible. As a Montgomery County, Maryland business owner, there's it's giving us a bad name when acupressure is used versus a licensed practitioner, and this bill will help to protect the communities and from exploiting vulnerable individuals. The board and I request a favorable vote on House Bill 374. Thank you for your time.
Thank you for your testimony. Do we have any questions from the members for this panel? Oh, Delegate Hill.
Thank you. You all were talking a lot about acupressure, and thank you for the bill, Delegate. But this bill actually talks about acupuncture. So I guess the first question, are you using acupuncture to include, because up above you talk about manual therapies, and it seems like you're using the term acupuncture, which many of us in the lay area understand that to be with needles, and you're capturing acupressure, reflexology, all that stuff, any hands-on with a massage therapist or anybody else doing, you're putting that all under acupuncture?
No, and reflexologists, as you know, actually in state law are an exemption under massage law. So, but we did talk to them about how it's impacting them because they'll say they do all of this in these illicit spas. And they were a part of the group that also helped craft Montgomery County's original bodywork law. So that's how we pulled the reflexologists in. But if you look at our statute in 1A101, the definition of acupuncture is what encompasses all of East Asian medicine, and that's how it was written over 30 years ago. So our law doesn't go and say acupuncturists do 25 different things. It talks about the fact that acupuncture means dietary therapy, therapeutic exercise, the manual therapies, the application of moxibustion, as well as the needles. So it encompasses everything. It says this is the definition of acupuncture for this board in this state.
May I follow up? Thank you. So this reminds me of sort of what we went through with dry needling, where it seems like you're talking about a legitimate trained specialty that is also trained in other areas. And so we've got letters here, and I guess in opposition from various other professionals, and I don't see physical therapists here, but I can imagine that they would also take exception that you need an acupuncture certification in order to do some of the things they do. It seems like you're capturing all kinds of manual manipulation.
And we're not. We're not actually. I think the confusion with that is physical therapists, chiropractors, massage therapists, of course, are all providing some type of manual therapy. Everybody's theory for manual therapy is different. Chiropractors are going to talk about high and low velocity adjustments. We don't do that. Physical therapists are working on muscle and trigger points. We don't do that. Massage therapy is doing something else that we don't do. This bill actually helps address a gap. The Massage Therapy Board came through a few years ago and got their law updated to address people who aid and abet. Because people don't understand that the board regulates acupressure, they feel like it's a non-regulated holistic massage that they don't have to get a massage therapy license for. And that is the reason for some of the opposition, because the people that are doing massage don't want to be sanctioned by the massage board or have to get a license. And in many cases, when the massage therapy board gets a complaint and goes to do the investigation, they'll say, oh, we're just doing acupressure, so you can't sanction us. We're not doing anything wrong, and we have a bodyworks license. Then when we do the investigation and say, well, you know, acupressure is East Asian medicine, in the investigations, they say, oh, no, we don't want to do that. We're not doing that. So, you know, they fall in this gap about how can you sanction and what can you do with them.
Okay, and the final question, where does reflexology fall in?
Reflexologists, when you look at a lot of these body workshops, they'll list all these things that they do, which includes reflexologist. And it doesn't mean they're doing reflexology either, which is additionally mapped work, but they're not licensed by the massage board or the acupuncture board right now in the state. They're under an exemption. So the state knows they exist, but they don't have to get a license. So we talk to them because it could impact honest reflexologists who are credentialed if they are somehow misconstrued to be providing illicit work.
All right, thank you, and thank you for your leniency.
Delegate Riley.
Thank you, Madam Chair. Yeah, so I'm looking at a letter here, and it says it's incorporating, they're in opposition, and they said that there's many colleagues that do currently massage therapy, physical therapy, and chiropractic, and that all of those already within their training and when they were taught in school received this, this specialty from TCM, that we're talking about here, the aquapressure. So they're saying they already do this. So will your bill cause them to have multiple license if they're, I mean, because obviously they feel like they are trained in this. and each one of them have their license, whether it's the massage therapist or physical therapist or chiropractor. So if they're doing this, are they going to be in violation and be charged the fee, or can they go back and get another license? I'm a little confused, so if you could explain
So
that,
if,
I'd
I
appreciate
think
it.
if you're referring to the complaint that I think that you're referring to, it's attempting to be quite frank, to gain power by saying everybody does this. And this is probably one of the people who are encouraging the misuse of the practice and saying, I can teach you this in a weekend over the computer, not even having done any clinical practice to make sure you understood what you do. I don't know of any physical therapists who would say they are using acupoints or meridians to practice, or any chiropractors. They do manual therapy, but I don't think there are any curriculums either that say we do TCM-based massage or manipulation. And they want to make sure that we're not trying to say that they can't do manual therapy, and we are not either. We're just making clear that our manual therapy includes acupressure. You need to be trained and licensed, and it is not a weekend certificate. And in that, we would be able to, when they go on these, when the police do these raids and they find people who are living in the places where they have to work and they're not being let out, or they have to perform sex acts and they're coming and saying we're doing acupressure. The complaints are very interesting, I'll just say, when we get them. You know, so, and the people, there is also a group of people who honestly don't have a lot of money to go to school, but they want to find an honest way to support themselves. And it's not fair that they invest in this course, and we've been told, I thought I was licensed. I thought I was doing the right thing.
Thank you.
Yes, ma'am.
Thank you, madam.
Seeing no other questions, I have one, because I'm also looking at a letter of opposition. I'm just trying to understand, I think to Delegate Riley's question, what the nexus is in some of this. And it's speaking, the letter of opposition, it speaks to your concerns about trafficking and about bad actors, but also says, as I'm a nurse, I'm aware that acupressure is taught to nurses in continuing education courses and is supported by the American Holistic Nurses Association, the Nurses for Natural Health, the School of Modern Nursing, and approved by C. Broker and the American Nurses Credentialing Center as a continuing education course for nurses. And I think it begs the question, if these are advanced practice education courses, do they then need an additional licensure outside of their other health occupation? And I think that's sort of what we're trying to understand.
And to address it, and hopefully a sort of indirect but clear way, we have also found that just because you call it acupressure doesn't mean that's what you're performing. You are offering a massage that is helpful for your patients, but it is not based on East Asian acupoints and meridians. That term has been hijacked, right? And we're not trying to take anything away from someone who is trying to help their patients. You can rebrand what you're doing and still do it, but it is not East Asian medicine that you're performing. And if we don't unmuddy the waters, it's going to damage the legitimate practitioner's practice, and they're going to be associated with a lot of illicit business.
Thank you. That's actually very helpful. Thank you very much. Seeing no further questions from this panel, thank you very much for your testimony. I do have another favorable panel, and a favorable with amendments and an unfavorable. So let me start with my favorable. I have Amanda Rodriguez and Dawn Lutke.
Chair Bagnall, Vice Chair Cullinson, my name is Amanda Rodriguez. I am the co-chair of the Legislative Committee of the Maryland Human Trafficking Task Force. The task force was formed in 2008, is made up of law enforcement, victim service organizations, survivor leaders, government agencies, and local task forces. The task force has facilitated the recovery of thousands of survivors of human trafficking and prosecution of hundreds of human traffickers statewide. On its face, this bill may not appear to be a human trafficking bill, but this bill does support the eliminating of human trafficking in our communities. I am also a former prosecutor from Baltimore County, where I handled all of the cases of human trafficking for almost a decade in the county. Task force partners have found that numerous labor and sex traffickers utilize illicit massage businesses, utilizing this loophole for acupressure and body work as fronts for criminal enterprises. However, when regulating these businesses, they deny utilizing traditional massage techniques, which would allow them to exist on the fringes without regulations. Survivors in these cases often have threats against their immigration status and families, making it nearly impossible to engage in services and the criminal justice system. As a result, the criminal enterprises often see little to any repercussion for their criminal activity. I want to briefly paint a picture for what these survivors in these cases often go through. They're required to sleep on the same table where they're forced to perform sex acts, completely isolated from the outside world. They have strict quotas that continue to coerce them to comply, often performing more than 10 sex acts per day. In one case that I prosecuted, the trafficker opened illicit massage business after illicit massage business in Baltimore County on the same street, just one building after another. Ultimately, they were, in fact, prosecuted by Baltimore County, at which point they moved to Montgomery County. In the case of this trafficker, when she had a business in Baltimore County, she had a sign on her wall for her victims that said, it was written in both Mandarin and Korean, that noted that any disobedience would be met with beheading. Currently, there's no delineated regulation for these types of therapies, which allow these enterprises to continue. Based on that, the Human Trafficking Task Force would urge a favorable report for HB 374. Thank you.
Good afternoon. I think it's still afternoon. Chair Bagnall and Vice Chair Collison. I am Councilmember Dawn Lutke from Montgomery County. I sit on our council's Health and Human Services and Public Safety Committees, and I also serve on our county's Criminal Justice Coordinating Commission and our Human Trafficking Prevention Committee. I respectfully request a favorable report on House Bill 374. I want to thank Ms. Tiffany Smith-Williams for her explanations that she gave all of you about the nuances of what flows up into and is part of acupuncture, and also just appreciate that this is solving two problems at once. One, it's protecting public health. Two, the human trafficking issue is very, very real, as you just heard. And I will tell you that locally within Montgomery County, we do have a local body work statute that allows for, since we've talked numerous times today about unannounced inspections, does allow for unannounced inspections of these facilities. I have gone with our vice officers to do these. This is not something you want anyone being subjected to. And this is one solid way to provide us with some tools that we can use locally and across the state to assist vulnerable people who are being exploited and members of the public who go in thinking they're receiving some kind of health service. And the folks who are in there are trained not at all to do any of it, but they are also living in the very rooms / tiny cubicles with curtain thrown up that they are forced to work in for 10+ hours a day. Some of them can't tell you when they got paid, if at all. The number of Vaseline containers I discovered under one table was absurd and indicative of the acts that you just heard about. So please, I urge you to take favorable action on this. It may need amendments, but please do close these loopholes. These are significant and we need more tools. Thank you.
Thank you for your testimony. Are there questions for this panel? Delegate Hill.
Of course. Thank you. So thank you, guys. As far as the sex trafficking, we've had legislation here, like under massage, where we had to change some things because the board was able to do inspections of licensed facilities, but they couldn't do inspections of unlicensed. So looking at this bill, if you're talking about sex trafficking, is it about licensing the legitimate or also, or alternatively about saying that we give someone the authority to inspect anyone who is promoting that they're offering a service, whether they have a license or not? It's the promotion of the service that seems to be at issue here. People who aren't certified, who are saying it's acupressure or acupuncture when it's not, who are doing any kind of body work. And if you need a license for an oversight body to go in, then isn't it sort of the reverse? We want to say, if you're putting yourself out, then we can come and inspect you and find out if you have a license and find out if you're who you say you are. And if you're practicing accurately without a license, then we can fine you or do something else. And if you're not doing it, then we can actually have you arrested for assault.
Right, so we're trying not to penalize the workers who are being exploited. Okay, so that's part number one. Part number two is pages 4 and 5 of this bill as written address the enhanced, the criminal and civil penalties that could be taken against the quote unquote employer, right? So locally, they may get an authorization to open the business, right? But the people who are working in there are the individual people who should hold a license to do the work through the board, right? Or through the massage board if it's for massage, et cetera. So the provisions on pages 4 and 5 that allow for civil and criminal penalties to be taken against the employer, or the business owner, who hasn't ensured that the people working for them have these licenses, which, to be fair, we do that in the childcare setting too, right? Like if you run a daycare facility, you've got to make sure everybody who's working in your facility is up to date on all their credentialing, and inspections are allowed to come in. You go in and you review the paperwork and you make sure everything's copacetic with COMAR in the childcare setting. Well, we need this tool here, except this is to prevent criminal conduct and or public health harm to the clients or people who are coming in who may be receiving services, who think they're there to get legitimate services and aren't actually attempting to engage in sex acts with the workers.
I'll take it offline, thank you.
Delegate Shalega. Thank you, Madam Chair. Thank you for being here. Is it Amanda, Baltimore County? This is disturbing. Like, how could you not, what other tools do you need? That you anecdotally talked about a woman who set up a, human trafficking shop after sex trafficking. It's just disturbing. How could that person not be arrested and put in prison and those workers freed?
Yeah, it was a really unfortunate case in Baltimore County, and I think she opened at least 4 facilities in Baltimore County before moving to Montgomery County, and we were never able to fully prosecute her. A lot of that has to do with victims who are not in a position to be able to testify because of their immigration status or threats against their family, and ensuring that there's culturally responsive services within the different counties to respond to these survivors. And so I think in terms of tools, more funding for victim service providers so that we can meet the needs of the survivors in our communities. And also, one of the tools that we know works is correct licensing and zoning so that people can go in addition to law enforcement to ensure that these businesses are legitimate and are, in fact, doing the things that they're saying that they're doing.
Thank you.
Yeah.
Delegate Lopez.
Thank you, Madam Chair, and thank you both for your thoughtful testimony. In part, I'm asking this question so the record can show that Councilmember Luedtke and I are 2 different people.
We are in fact different people.
Confused for each other many times in Montgomery County.
By our own constituents, yes.
Yes, our overlapping constituents. But as Delegate Shalega was asking her question, I started thinking too, are there other bills that are in circulation this section that are complementing the work that you're doing here that go after the customers at all, or any type of enforcement that we should be aware of?
I do not believe that there are any demand-based bills this session. It is something that we have looked at many, many times and are often met with at least some pushback, but yes.
And I know, for example, one of the things we're doing, we just launched a public service campaign announcing education for consumers. Like, it's called Look Before You Book. Like, what do you think you're getting? Hey, was that Groupon, I don't want to throw Groupon under the bus, but was that Groupon deal too good? And are they only taking cash? And what are you supposed to be looking for in terms of licensure? And how can you go on our state's sites and determine if the person you're there to go see is in fact credentialed? All important tools to making sure that consumers are protected and getting what they think they're getting. We also have been embarking on going after landlords where these businesses, like let's say our inspections, our vice inspections have already gone in and they've determined there's been non-compliance, they don't have licenses, they're violating our local law, then they are notifying the landlords if there's other evidence of them engaging in this kind of conduct, the hours that they may be open, like if it's open 24 hours a day, it might not be what you think it is, right? And other assorted things to let them know if you continue to allow this on your property, you will be prosecuted.
Thank you.
See no further questions from our members. Thank you very much for your testimony. Delegate Taveras.
Hi, Councilmember Lucky.
Hi.
Just making sure I understand, when you say that you're prosecuting the individual, you're commenting on the landlord or the?
So, yes, the last comment I made was that they are trying to target landlords where landlord is knowingly allowing the criminal conduct to happen on the premises, right? And letting them know, hey, this is happening, this violates these different laws, you need to take corrective action as the landlord, and then could go further if necessary, if no corrective action is taken.
That was very effective for me as well when I was a council member. So just, if you want to see the law, I can give that to you. Thank you.
Yep.
Thank you very much. Seeing no further questions from our members, thank you very much for your testimony. I do have a favorable with amendments, which is 1 in person and 2 virtual. So I'm going to go ahead and bring all of our witnesses up. Donald Hirsch, if you can come to the table, and also if we can bring up Tuesday Wasserman and Amy Magger. And Mr. Hirsch, you can get started as soon as you're ready.
Thank you. Hey, thank you very much for the opportunity to testify support of House Bill 374 with amendments. First of all, thank you, Madam Chair and Vice Chair, and congratulations on the new and improved Health Committee. And I must say, I've attended many hearings. You're doing a great job chairing. I think that should have been noticed. So, the Maryland Chiropractic Association, I am the chairman of the board, and I'm the chairman of the Legislative Committee. And obviously, we read the bill, and we would like to ask for a clarification amendment. The chiropractic profession knows a lot about manipulation. We have hundreds of hours of didactic education and thousands of hours of in clinical setting. And it's a very important task to learn that craft accurately. The way the bill is written, where it talks about manipulation, it could be confused. The confusion could harm the public, certainly, and unfortunately, vagary and confusion do not do well. And in statute is the place that these are best handled. So we understand that the acupuncture curriculum and the practice of acupuncture, they're well trained in manual therapies. We appreciate what they do and how they do it, and we're very respectful of that. In no way is our amendment to add clarification on the manipulation to remove the ability to do things like high-velocity manipulations. So it's clarification on a word that can be confusing. And once it's in statute, it creates lots of missed opportunities. So we very much support the other aspects of the bill. We hope the bill passes, and we certainly hope our amendment is taken very seriously. Thank you very much.
Thank you for your testimony. We're going to go to our virtual witnesses, and if you can just remain, and then we'll take questions of this panel. Tuesday Wasserman, if you want to go ahead and unmute and start your testimony.
Thank you, Madam Chair and members of the committee.
Thank you for all of your work and for all that you've done today in supporting this. I'm here on behalf of the NCBAHM, formerly the NCCAOM, the National Certification Board for Acupuncture and Herbal Medicine, and we appreciate the opportunity to support HB 374 with recommended amendments to clarify the language regarding certification requirements. The NCBAHM offers the only national certification for licensed acupuncturists through third-party psychometrically validated examination. And the language as it's currently presented in the bill implies that there is only one NCBAHM exam for certification. And previously in the 90s, that was true, but since 2004, acupuncture certification through NCBAHM requires 3 or 4 examinations. The 3 examinations include acupuncture with point location, foundations of Oriental medicine, and biomedicine. And then there's also a Chinese herbology exam for herbalists. And we highly recommend you consider updating the language to clarify that NCCAOM certification for acupuncture includes those 3 exams, which is very important when it comes to public safety, especially because the biomedicine exam is where candidates demonstrate competency and qualification when it comes to referrals, appropriate referrals, red flags, interprofessional and interdisciplinary communication, and ensuring public safety, as well as the competencies that are demonstrated in the acupuncture with point location and the foundations of Oriental medicine. Thank you again for your time. I'll remain if you have any questions.
Thank you for your testimony. And Ms. Mager, if you want to go ahead and unmute and start your testimony.
Thank you. I'm Dr. Amy Major, DACM licensed acupuncturist. I am the Federal Advocacy Chair for the American Society of Acupuncturists. I serve also on the NCBHM State Relations Task Force, and I also serve on the NCBHM Foundations of Oriental Medicine Question Writing Exam Development Committee. And I'm here to support HB 374 to ask you to report it favorably out of committee with amendments. I concur with the NCBHM's position that it is concerning that the examinations have not been identified, that examinations do need to be 1, identified, 2, psychometrically valid, and 3, be able to demonstrate competency and the ability not to harm to protect consumers in Maryland. I also want to support the chiropractic amendment and the idea that holistic nurses who can, when appropriately trained, be certified or have a certificate, there isn't a certification, but there is a certificate program for acupressure. And these are advanced practice individuals as opposed to massage therapists who may be offering a happy ending and may be offering something that is valid, and we don't know. And this is why specificity is queen, just like in ICD codes that we use for billing and CPT codes for procedure codes. You know, what we call gua sha, chiropractors may use as Graston. What acupuncturists do use trigger points, and that is it's not part of acupressure, but it is a part of what we do as part of the Neijing. I thank you for your help, time, willingness to listen to us all. And if you have any questions, I am most happy to answer them.
Thank you for your testimony. Do we have any questions for this panel? Any questions from the members? Seeing none, thank you very much for your testimony today. We have one more panel. We have 2 unfavorables. They are both virtual. So if we could bring up Tom Swiss and Victoria Goldston. Thank you for your testimony. Do we have any questions for this panel? Any questions for the members? Ms. Goldston, can you turn off the live stream? And let the record reflect that Tom Smith is not in the waiting room. But Ms. Goldston, if you can turn off the live stream and then go ahead and unmute and begin your testimony.
Okay.
We can hear you. You can go ahead and begin.
Okay. Hello?
Please begin your testimony.
Yes, this is Victoria Goldston, and I am in opposition to the SB 037, excuse me, S370, HB 0374. I am a nurse and a massage therapist, and I'm notifying you that I'm in strong opposition to these bills. As a licensed massage therapist since the inception in the year 2000, a licensed nurse, and an acupressure instructor since 2002 in Maryland, trained in acupressure, shiatsu, manual therapies, and East Asian traditions. I know they are safe and effective methods provided by trained and certified practitioners, and that the methods are not exclusive to acupuncturists. Nor is acupuncture training and licensure necessary to perform the methods. It is by far an extreme overreach to require such extensive training in acupuncture to perform the bodywork methods. My clients and students have greatly benefited from my ability to provide and teach these therapies. I am extremely disappointed and upset to learn that the Maryland General Assembly is considering a bill which would end my ability to provide these treatments to my clients, provide my knowledge to my students, as well as being drastically detrimentally affected by my livelihood. I am aware that after receiving education in acupressure, shiatsu, manual therapy, that many practitioners, such as physical therapists, occupational therapists, nursing staff, chiropractors, estheticians, spa practitioners, certified acupressure practitioners, as well as massage therapists, perform the acupressure method, and it is not exclusive to acupuncturists. As a massage therapist, I'm also aware that acupressure is part of the massage therapy curriculum, and it is also recognized as continuing education by the National Certification Board for Massage Therapy and is recognized by the Board of Massage in Maryland. As a nurse, I'm aware that acupressure
Can
is
you
taught
please
to
wrap up your
nurses.
testimony?
Excuse me?
Can you please wrap up your testimony?
Yes, I just wanted to let you know that the Nursing Credentialing Center also approves acupressure, and that we are aware that the human trafficking problem is an extreme issue, but we do believe that our certified practitioners and licensed practitioners that can practice the method. And I also had supporting documents from the Holistic Nurses Association and the American Naturopathic Association.
Thank you for your testimony. Your time is up. Do we have any questions for this witness? Delegate Hill.
Thank you very much. I just want to get some clarification. If the purpose of the bill were not to stop you from using the techniques you trained in, but to have boundaries on your advertising that you're doing. In other words, you're doing other things, and one of them is you're putting pressure on following what you've been told is acupressure. If you simply were advertising but you didn't say I do acupressure, would that still be a problem for you? In other words, you can use the techniques, you just can't call yourself an acupressure provider. Would that change your position?
It is problematic because people are familiar with the term acupressure. And I actually was instrumental in helping with the exemption under the massage laws when it first came into effect in the year 2000, where acupressure was the intent to move energy. And I actually met with, and even my teacher, we met with multiple staff members under the direction of Jim Vallone, who was the director of the chiropractic examiners. And we specifically reviewed the techniques that we would teach so they would not violate the massage laws. And we went by them explicitly. We followed their rules to the T. and taught people acupressure based on how the chiropractic examiners told us we could do it. And there's many people such as myself that have been in it, over 20 years practicing acupressure.
Okay, thank you very much.
Thank you.
I'm going to go, I just realized that we do have Tom Swiss in our virtual window. So Mr. Swiss, if you want to go ahead and unmute and give us your testimony.
Thank you. Had a little technical difficulty there, I think. So I'm very happy to be able to address the committee. Delegates, my name is Tom Swiss. I am one of the people who could be criminalized by this bill. I'm a graduate of the Shiatsu and Asian Bodywork program of the Baltimore School of Massage, certified as a diplomate in Asian bodywork therapy by the NCB-AHM, a certified practitioner of the American Organization for Bodywork Therapies of Asia, and a licensed massage therapist. I've practiced massage and Asian bodywork therapy for 2 decades. I'm on the faculty of the Potomac Massage Training Institute, but now I'll have to warn students that acupressure may become forbidden knowledge. Under this bill, if a massage therapist rubs a point and calls it an acupressure point, that's acupuncture. But if they call it a trigger point, they're just fine. Will it be criminal to even know that the point is gallbladder 21? Acupressure is not acupuncture any more than massage is surgery. Like reflexology, it is a simple and safe practice that is a minute to learn and a lifetime to master. I'm also a member of the medical staff of Mercy Hospital. I work with cancer patients there. That's just one example of how this work is valuable to the people of Maryland. By imperiling it, this bill reduces healthcare access and does real harm. I want to tell you a human story about this work. Just before I learned about this bill, I learned of the death of a patient I've been working with for years. I was there a few months ago when she learned that cancer was infiltrating her brain. I tried to take away some small part of the grief and pain with my hands. And then that same day, I learned about a bill that proposes to incarcerate people who do this work. So if I sound angry, I hope you understand why. Regarding human trafficking, no one would suggest that the way to address trafficking in agriculture is to make field hands get degrees. The appropriate target is employers or enslavers, not practitioners. And because some vulnerable women train in highly accessible therapies like Reiki or acupressure as a formal or informal employment, this bill works against them. I believe this bill is ill-founded and cannot be saved by amendment. I urge you to oppose it, but I will follow up by email with suggested amendments to partially mitigate the disaster. If it does pass, I'll be happy to take any questions. Thank you very much.
Thank you for your testimony. Are there any questions from the members for this witness? Seeing none, thank you very much for your testimony today. This concludes the bill hearing on House Bill 374 and concludes our bill hearings for today.